Hello, everybody. Welcome to the 2022 Guide to the Transplant List Conference. I am one of your collaborators, Philip Jones, of a second chance and kidney transplant recipient, and I'll pass it over to Tafaro Cook.
Hello, everybody. My name is Tafaro Cook, two-time kidney transplant recipient and founder of Kidney Care Coaches, where we coach people with stage 3 to stage 5 kidney disease.
Mr. Trailer.
Hello, guys. My name is Jonathan Trailer. I'm host of Hope with Jonathan, plant recipient, and I look forward to this event this evening. Thanks again.
Appreciate you, Mr. Trailer. All right, well, we'll turn it over to our host for tonight, Mr. Fred Hill.
Good evening, good afternoon, wherever you are. Here it's 6 o'clock in afternoon for me, evening for me. So listen, I am Fred Hill, excited from Dialysis It's Not Your Life. It's the foundation that we've started, but we want to welcome everyone to the 2022 Guide to the Transplant List Conference. We're excited. We have awesome speakers today that will be sharing and helping us all out. So I ask everyone, if you have any questions, just put them in the chat and we're going to go from there and make sure we get everything answered. Just want to give a great shout out to all the collaborators that are here that really helped us out, but a big thank you to Philip Jones of A Second Chance for really reaching out and getting all this together. So I'm going to go ahead and do this to you, man. I appreciate you, and also for having me here today. I'm excited because we have some awesome speakers. And today we're going to start today with Dr. Sharika. Did I say that right? Sharika Brookins. Sharika Brookins, MD, FASN, is a kidney health physician on a journey to empower others about nutrition, disease prevention, transplantation, and health disparities. Dr. Brookins is a board certified nephrologist and internist in Georgia. She is the founder and CEO of Remote Renal Care, a telehealth kidney private practice, and the first of its kind in Georgia. Dr. Brookins is a published author in medical scientific journals and digital media, a member of leading medical societies, and featured on WebMD, Medscape, ABC News, Women to Watch, and C-SPAN with the USDA. So everyone, please help me welcome Dr. Sharika Brookins. Welcome.
Thank you, Mr. Hill. And thank you guys, Tafaro, Philip, and Jonathan, for inviting me back for another one of your great conferences. I remember doing the blood pressure and the diabetes one recently. So it's always a pleasure and an honor to join you all and your online community when it comes to bringing, awareness to kidney disease and transplantation. So my take today is to share with you some tips on preparing for transplantation and the do's and don'ts of once you get on the kidney transplant list. So I do have a presentation to share. And can you all see this?
Hold on 1 second. I got to bring it in.
Oh, okay. So I'll just, before we start, and you can see the actual presentation, but one of the things that I did in the beginning of January, in the month of January, this is where we start new goals. Everyone wants to start anew. So what we created was 5 steps on planning to have a new kidney. So that's what I'm showing today for those who are viewing as well as listening. This 5-step guide is on our website, which is remoterenal.com. And so we'll start with steps 1, and that is pretty much discussing with your general nephrologist. Now, before I dive into step 1, I will say, I think one of the most important steps is to acknowledge that this is something that you want to do and be prepared for this commitment and having patience, because the kidney transplant process, as well as most other transplant processes, but more specifically the kidney transplant process, requires a lot of patience. Generally, the wait time for kidneys is a lot longer than the other organs. So this does take a lot of patience. Are you able to see this first slide?
Yes.
Yes. Yes.
Okay. All right. So with starting out to plan for a new kidney, now I am a general nephrologist. So this is kind of what I walk my patients through when we're planning for a new kidney. So the first step is to actually have that discussion with your general nephrologist. And these are just a part of that step one. Once we determine that, yes, we are, we are someone that would consider, we as in my patient, they would consider getting a new kidney, giving them this checklist. So the first thing would be to evaluate your EGFR. And simplified in layman's terms is what you may be told from your nephrologist about what is your percent function. Now we know technically it's not really the percent function, but in layman's terms, it's the best way to explain to you how well your kidneys are functioning. So looking at your EGFR, at least for the past 2 to 3 years. This is important because you're able to see the trend that your kidney function is taking. So if 3 years ago, from 3 years ago to 2 years ago, your EGFR has declined by maybe 5%, and you notice that between 2 years and 1 year that it's also doing 5%, then you can kind of anticipate maybe just how long it will take you until you get to that threshold. So gathering up your kidney function values for the past 2 to 3 years. And this is important for people who are more so around a stage 4 to kind of prepare yourself for your trajectory of your kidney disease. The next step would be to see if those values have dropped by over 15 within 3 years. And so if you're at, let's say, 30%, and you've noticed, well, 3 years ago I was 45%, then unless you're making any changes in your diet, in your medications, in your fitness, unless you are not making any changes, there is a likelihood that you could drop another 15 points in 3 years. So just mentally getting prepared to where your kidney function could be in another 3 years. And so the next step would be to discuss your transplant goals with your nephrologist. And your transplant goals, that's very general, but the most important thing is making them aware of, yes, I would like to have a kidney transplant if that topic has not been brought up to you already. So even if you are at 30%, you should have still had the discussion about whether or not you want to transplant, either just a yay or nay. However, once you do get to 20%, you do qualify for being placed on the wait list. And at that time, you would want to decide on what will be your transplant center of choice. So I know here in the state of Georgia, we do have 3 transplant facilities, 4 including children's, but we do have 3 transplant facilities. So one of the things that I review with my patients, we may have this one center locally, but there are other centers that you could select to be your primary center. So which would be your primary center of choice. And then at that point, once we get to 20%, we will proceed with the referral to the transplant center. So this step one plan is definitely for those before you get to 20%, but it can also apply to those who are at or below 20%. And I also like to say this isn't just for those who are non-dialysis. If you are dialysis and maybe never had that discussion, it's never too late to have the transplant discussion. Step 2. So on the step 2 action plan, we have the first item on the checklist would be to prepare to travel for a visit. to have a visit with the transplant nephrologist. So, for instance, if my patient locally said they wanted to list a transplant center that was outside of our town as their primary, then they have to be prepared to have that initial visit with the transplant nephrologist. Now, I know since the past 5 to 10 years, offering remote consultations has become more common, especially if the distance is over an hour or so. Some centers do allow for initial remote consultations. The next step is to gather up to date information on your medical history, your surgical history, and your social history. Now, once we prepare that referral that goes on to the transplant nephrologist, they will have this information. But I always want to encourage people to be armed with having this information on their own, right? So, understanding what is your medical history, knowing your surgical history, as well as your social history. So don't just leave it in the hands of your referral coordinator and the transplant centers. So once you have that initial evaluation from the transplant nephrologist, and once they've reviewed your medical history, your surgical history, and your social history, they will then determine and give a recommendation on if they consider you as an ideal candidate or if you're not an ideal candidate. Now, if you are considered to be not an ideal candidate, I would definitely encourage you to make sure and understand why you're not considered an ideal candidate, and if there's something that you can do, or if there's a step that you can take to be reconsidered, right? So, for instance, an example in which you may not be an ideal candidate would be if you're a smoker. But if you know you're willing to quit smoking, then that's a step that you can take and have and be reconsidered for being an ideal candidate. Now, I also will say some centers do vary in what they have as hard absolute contraindications for putting someone on a transplant list. But I know that smoking is one. One center I was at where it was a hard and fast disqualifier. And then there was another center where they would consider you. However, you did have to agree to go through a smoking cessation training and program. So step 3 would be to prepare your schedule to meet with other members of the transplant team. So once you're considered an ideal candidate, the next step is now you have to meet all the other members of the transplant team, which actually consists of, in some places over 6 different specialist professionals that are on this team. So you have a social worker, you have the surgeons, you have case managers, you of course have your transplant coordinator, you have mental health, you have whatever subspecialists, whether it be cardiology or GI that you're referred to. So your transplant team could consist of a lot of different professionals. And just like no two plans for kidney transplant are the same, so is your transplant team. Your team may consist of more members than someone else's team. The next step on this action plan is you will complete lab testing for an immunity profile. So now you've determined you want a transplant, you've been evaluated, and you've been deemed to be an ideal candidate. Now, what you have to have determined is what's your immunity profile to kind of help us understand what's the likelihood of rejection. And also, once that kidney arrives, what's the best paired kidney for you to take on. So there's a battery of testing that you have to undergo, which pretty much helps us to determine your immunity profile. And the next step would be to finish imaging tests to evaluate various organs. So we do have you undergo various imaging tests, whether it be a cardiac cath, whether it be a CAT scan, whether it be a renal ultrasound, a chest x-ray. There are a variety of imaging tests that you have to undergo to look at different organs like your lungs, your existing kidneys, your heart. Those are definitely some of the main ones. And then, of course, you have your cancer screening imaging test that you do have to undergo. So once you complete all that, which becomes a part of your final package, you do have to meet with mental health and social work specialists. So they also become a part of your transplant team. I do know that during COVID, during the pandemic back in 2020 and even in 2021, we started to do these visits more through remote services in which the mental health specialists and the social work specialists were seeing individuals virtually. And then you also have to discuss plans with a financial counselor. And again, this can vary depending on the facilities and what aid and aids that they have available. So on step 4 of the action plan, all that information is put together in a portfolio, and then you are presented to the transplant review committee. And pretty much it's just like a round table in which everyone provides their updates on your portfolio, either recommendations on what needs to be completed if not completed, or giving their opinion on potential outcomes. So then those results, once your transplant committee has met, whatever they determine if you should go on to be on the list or not, that gets sent to your transplant nephrologist, which will then review it with you. So you not only receive notification from your review board at your center, but your transplant nephrologist also reviews with you whether or not everything is good to go, or if you were denied to get placed on the transplant wait list. So if you are denied, I do encourage you to express interest for reconsideration, better understanding why you are denied. And generally, the transplant review committee gives you a deadline. So they say, well, if you were denied because of the results of this test, you do have until this date to be reconsidered, to have things reevaluated and be reconsidered. So one denial doesn't necessarily mean that you give up. So always, if it's something that you really want to do, just express your concerns to be reconsidered, and just again be patient to go through maybe go through that part of the process again. And so for the step 5 of the action plan, if you are approved, then definitely celebrate your approval for being on the wait list. Now, at this time, you are on the wait list for a deceased kidney donor, but I do encourage you to get creative with your search for a living kidney donor. And, in the past decade or so with social media, a lot of people have been successful at finding their living kidney donors, whether it be through social media, through news media and print, billboard, just a variety of ways in which people have gotten creative. So definitely get creative, because your living kidney donor just may not be a family member. You never know. Also, what is important is to avoid changes in your immunity. I will say the pandemic has taught some of those on the wait list, unfortunately, how contracting COVID has put it on hold. So we have seen that individuals, once they were either notified of a kidney, that process has been put on hold due to either the living donor being positive for COVID, or even the potential recipient being positive for COVID, and having their transplantation put on hold. So it is definitely important to avoid any potential changes in your immunity. So that means get your appropriate vaccinations, and definitely staying clear of any situations and environments that could put you in jeopardy for that. If you do have some potential living donors, you want to refer them to your transplant center. So you don't refer them to your general nephrologist. You actually will receive a number to have your potential living donors contact your transplant center. And last but definitely not least, consider being listed on more than one transplant center. So you can be listed on more than one center within your state. You can also be listed on centers out of state. The most important thing is just to be cognizant of the time that it would take for you to travel to that facility if you do get the phone call. And so, lastly, I was told to just kind of give some do's and don'ts. So, if you are already on the list, you definitely want to stay in contact with your transplant coordinator. That's going to be like your closest person of contact when it comes to any issues, any questions or concerns that you may have. You definitely want to stay up to date on your screenings. So even if, something falls through the crack where you're not notified by a letter, still, do your own due diligence to make sure you have all of your screenings on your calendar and when you should have them done, because you don't want anything to delay or offset you being on the wait list. And if there are any changes, definitely notify your coordinator. So one of the things I encourage people is if you aren't sure of what the COVID guidelines are within your center, and notify your coordinator and ask them. So what happens if I develop COVID? They may say, hey, as long as you're symptom free, it won't stop anything over here at this center. But you may have some centers that say, well, if you develop COVID, we have to wait. Or if you test positive, you may have to wait 10 days. You just never know. So I definitely encourage you to find out what are the guidelines at your center. And for the don'ts, I would just definitely say don't give up. Regardless of what you're going through, if we're going back to step one, and this is a decision that you've said, I want to do this and I will do this, just have patience, have faith, get you a good support group and a close circle, and definitely do not give up on this transplant process. So that's all I have.
That right there was absolutely awesome. One
Thank
thing
you.
from the Why Not Impact Lives Network that said that information being shared within this conference is very informative and very much needed. Keep up the good work, you all. Now, for me, I'm a transplant patient. I actually had my transplant done in 2015. But one thing that up to me, I'm putting out is this main thing of everything as you went through the 5 steps for me, and for those who are watching, who being on dialysis or if you're in the last stages of kidney disease, of renal failure. You pointed out a lot of things, but the main key that I took out of this was it's really up to the patient. When you really brought this out, you said, okay, well, you need to talk to your nephrologist, and you need to know your EGFR, know where it is, and you need to reach out to your coordinators and all the things that you said. And me personally, that means everything, because sometimes many of the patients we rely on the doctor, or we rely on the coordinators to do the work for us. For me personally, I just want to say thank you for that, because that was absolutely awesome for us to know. But I do have one question. Well, I got 2 questions. It was talking about gather medical and surgical social history, and with this understanding that transplants, it goes with blood type. How do you find out your blood type? I just wanted to throw it in. Maybe that's a crazy question, but I wanted to know that, because I didn't know mine, and all I knew was I'm sitting up in there, and they said, okay, we ready for you. And the more I asked, I didn't get anything. And so until I got to MUSC, and they took me in. So is that right there for me to find out? I know I asked, but I did not get that answer even prior until I got to MUSC.
Yeah. So On average, most people may not know their blood type, but there are certain situations in your history that if you have had something done, you may know your blood type. Like, for instance, me as a mom, I know my blood type because of going through a delivery process with my daughters. I didn't know my blood type prior to that, right? Or if you've had surgical procedures, you very likely have reported somewhere your blood type because they're going to prepare for it if you need blood during a surgical procedure. So they will have tested you. Or if maybe you have received blood in the past, there's going to be documentation somewhere that where someone has already tested your blood type. I will say for those who are on dialysis, no, everyone does not have to receive blood who are on dialysis, but it's a more likely chance that you have had your blood screened or your blood type performed. So that should be a question that you are able to get from your dialysis center, especially if you've had to receive blood. So I think certain instances, we should already have that information on file. But if not, then remember once we got to that part of the plan where it was we wanted to look at your immunity profile, we'll get your blood type at that point.
Yeah.
And that's when it can be shared with you so that when you go on to find your living donors, you're able to share with them, hey, this is my blood type and I'm looking for a kidney. So at some part along that process, you will be made aware of your blood type.
Okay. Another question that I have is okay. You was talking about if you're turned down, and well, I got I guess it's a two part that if you're turned down, um, how long do you have to wait before you are recommended, or like you said, that you go and recommend that you be put back on the list? Is there like a wait period, whether it be 1, 2, maybe 2 years, or maybe months of the wait period before being reconsidered?
Unfortunately, it's not 3 years. It is a fairly short period of time where they may give you 6 months and they may give you 12 months. So, for instance, just recently, I had a gentleman who he had some questionable liver problems, and so they denied him. He was denied, but it was stated that if you got this thing either sorted out or if you got a final say from a hepatologist, from the liver doctor, you have until 6 months to get this done. So, of course, that means he needs to be made aware of this in a timely manner so that he can decide if he wants to proceed or if he just wants to accept the denial. But then now you have to get him into the liver specialist to say, hey, um, can you further comment on this? The committee is wanting more input on this issue. So they will tell you that deadline period, but it's generally not 3 years. They don't give you that long. Yeah.
Good, good. My last question that I have before we open it up to the floor, if you, like you were saying, you can be added to multiple lists, transplant lists. Now, the question I have is, if one of the people on the list, one of the transplant, if you're turned down for the one, does that mean that you're turned down for all?
Well, generally, in order for you to get on a second list, and this is just my experience, is you would have to be approved by one list because
Ah, okay.
although certain centers have certain guidelines. Like, for instance, there are some centers that do transplants on bariatric patients, and there are some centers that don't, right? So, certain centers can set their guidelines, but it's very likely that if center A says, well, you're not an ideal candidate because of this reason, it's very likely that center B would probably say the same reasons, right? Unless center A says, no, your BMI is over 35, but center B may have a limit at 40, or
Uh,
center B may have a limit at 38. And so they may accept you as
Mhm.
your primary center. But generally, it is advised for your first center to approve you. And then it's just easy to add on the second centers after that.
Okay.
Second and third for some people.
Okay. Well, I don't have any more questions. I want to open it up to those who are on the floor. If anyone have any questions that you would like to ask.
Yes, I do. First of all, I want to say that was a great presentation that you showed everybody. Is very, very informational. Can you elaborate and tell the people the importance of getting your teeth fixed? So when you are on the transplant list, a lot of people go and excuse me and go through this and don't understand the importance of having your teeth. Not, they don't have to be like put braces on and things like that, but just elaborate and tell people how important it is to have your teeth repaired.
So the dental care is important, and Dr. Geff could probably also add to this. But the dental care is important because we have to consider if you're undergoing any surgical procedures, the risk of dental infections seeding throughout your blood and maybe affecting your heart or maybe just affecting your immune system overall. So it is important that if someone has dental caries or if they have bad oral flora, to have that evaluated before to reduce their risk of further seeding infection throughout their body.
And how often do you have to get your teeth looked at?
I do know that in the beginning of the evaluation, you do have to have a dental evaluation. So it all depends on how your evaluation turned out, right? So if they say, well, you're someone you need 10 teeth extracted, then more than likely, once you have those teeth extracted, and as long as you don't have any other potential teeth that will concern in the future while you're on the wait list, that probably determines how often you need to follow up with the dentist. But given on average 3 to 5 years on the wait list, I think it just depends on the current state of your mouth.
Thank you for that. I appreciate it.
You're welcome.
Any other questions? We did also get we had a response from Trish Phillips. She said, "Great presentation, awesome, awesome." We just want to say thank you. It was awesome for what you did, Dr. Brookins. We really appreciate you taking the time to join us and share this information to all of us. And we just want to say thank you again for doing this for us and for everyone. We all appreciate your time. Thank you so much. Let's give her.
Thank you.
Thank you as she comes up.
You're
Appreciate you
welcome.
so much. Thank you so much. We're now have a break, and we're gonna talk about kidney care. So we'll be back in just a moment. Thank you.
DeFar, that's you.
Oh, sorry. Okay, sorry about that. Hi, my name is Tafaro Cook, two-time kidney transplant recipient and founder of Kidney Care Coaches, where we coach people with stage 3 to stage 5 kidney disease. Those that might not know that when I was on dialysis, and I did dialysis for over a decade, I own my own fitness studio, and I would create programs in the dialysis center to help patients who were waiting for kidney transplants or just on dialysis. So, what I do now is I coach people. I am what we consider your accountability coach. We coach people with stage 3 to stage 5 kidney disease. We work with them with 3 services. We have membership site, group sessions, and coaching with one-on-one patients also. Our goal is to hold you accountable and be your accountability coach as well. And that's what we do. We also walk you through the process and get you to understand what's going on with your medications, your nutrition, and your exercise, and also help you with coping mechanisms while you're going through this process. So if you know anyone who needs coaching with their kidney disease, hit us up at kidneycarecoaches.com. Thank you.
Right. Thank you, Tafaro. Is it back to me? Back. Okay.
Yes.
Thank you, Tafaro. We appreciate Kidney Coaches doing some great, great, awesome things for all of us with the kidney disease, kidney transplants, and also on dialysis. So we appreciate all that you're doing. Right now, we're going to shift and we're going to move into Dr. Hope I say this right, Dale Gift, MD. Did I pronounce your name right, sir? All right, well, make sure I got it right. MD is a board certified in advanced heart failure, transplant cardiology, internal medicines, cardiovascular disease, echocardiography, and nuclear cardiology. He earned his bachelor degree in
Turn that light up. Down.
philosophy and religion at Columbia University. He's very educated. Also went to Sackler School of Medicine, Tel Aviv University in Israel. And he did his residency in Cedars Sinai Medical Center, followed by the fellowship in cardiology. Gotta get these words right. My eyes kind of messed up. Subspecialty training in advanced heart failure, heart transplant, medical circulatory support, and pulmonary hypertension at Cedars Sinai. As well, Dr. Geff has a keen interest in both research and teaching, as he's published on a wide variety of topics and is actively part of many clinical trials. He gives lectures routinely to pre-med medical students and fellows, excuse me, and has spoken at various conferences. He's both nationally and internationally a resident. As a resident, Dr. Geff was awarded the Ben Newman Award for Excellence in Patient Care during fellowship. He received the award of Outstanding Fellowship of the Year. He is currently Associate Director, Pulmonary Hypertension Research and Education. Wow. We want to take time and we just want to welcome you today, Dr. Dale Gift. How you doing today? Just come on in. Come on in. How you doing today?
Great. Can you hear me okay?
Yes, we
Great.
can.
Thank you so much. Thank you so much for having me. This is I don't know, the second or third time I've been privileged to be part of an amazing presentation and program like this. I really appreciate the offer to be part of this and to be part of this panel. You guys do amazing work, and I really applaud you for that. I'm also really happy to be following Dr. Brookins because that was an amazing presentation and so well organized and eloquent. And a lot of those steps are the exact same steps that heart transplant patients have to go through as well. There are clearly some differences in the world of heart transplant from kidney or liver or other organ transplantation, and I'll emphasize some of those differences. But you know, a lot of them really overlap, and in many ways they're very similar. I know that I'm sharing my screen here still in this mode. If I hit slide mode, I just wonder if it can still. Is that better?
I can see it.
Can you see it fully? Okay. Yeah. All right. So, how does one get themselves prepared to be a heart transplant recipient, to be a candidate for that? And as Dr. Brookins said, once you are on the list, how does one make sure they stay a good candidate on the list? Because it's important to remember that once on the list, there's nothing finalized. It's fluid. It's something that can change over time, because depending on where you are on the list, what your urgency is and what your status on the list is, you may be waiting for days to weeks to months to years, and things can change over time. So it's very important to be aware of that, to be on top of certain things. Now, I'm trying to move. Let me see. There, did that work? Okay. Everyone should be well aware of the fact that heart failure is still such a huge burden across the world in terms of health and also in terms of finances, and on just what a burden this plays on in our country especially. even with the incredible advances in therapy that we have today that I'll go over briefly, we still have a very high and unacceptable mortality rate and a very high readmission rate to the hospital. These things really have improved significantly, but need to be even better. Now, how far have we come in the world of in the world today? I love this slide that I found once. In 1998, we were telling people, don't get into strangers' cars, don't meet strange people from the internet. And now we literally summon strangers from the internet so we can get into their car, Uber and whatnot. So that's not, in many facets of life, we've come a very long way. But in the world of heart failure, we've actually come a very, very long way as well. And it's important. The reason I'm emphasizing this before I get into the actual details about being on a transplant list is it's crucial to understand how far we've come and how many therapies there are today that have shown to improve survival and improve symptoms, keep people out of the hospital, because you really want to make transplant a last option. You want to delay it as much as you can in most cases, and hopefully prevent it if possible. So if you look back here in 1984, if you looked at the kind of therapies one had for heart failure of different stages of heart failure, we see there really weren't that many options. You had diuretics, which we still, of course, use today. We had a medicine called digitalis or digoxin, which we still use today, but much less than we used to. And we had vasodilators, not exactly the type we have today, but I mean, we do use those same ones, but we have better ones today. The point being that none of these really at that time showed improving survival. They were really just symptomatic treatment, and you were very limited in how much you could do. But fast forward to today and look at just how many options we have to optimize people's heart failure, improve their symptoms, keep them out of the hospital, and keep them living much longer, and potentially to avoid having the need for a transplant or mechanical type of device at some point. We have beta blockers. We have, you may have heard of Entresto, one of the mainstays of therapy now. These have been shown to improve survival, even given to patients who are basically asymptomatic. We already have so much treatment to just improve people's heart function and survival. Beyond that, we have other medications. Beyond that, we have device therapy like defibrillators, certain special types of pacemakers to improve synchrony of the heart and improve heart function and survival as well. There's been newer medications added just in the last few years that have already made it into the guidelines within 1 to 2 years and are the mainstay of therapy today. So you could just see where we've come and how far we've come to really, really improve people's lives, both quality of life and quantity of life. Now today we have something called SGLT2 inhibitors like dapagliflozin you may have heard of. These are things like Jardiance and Farxiga, diabetes medications that were discovered now to be incredibly helpful for heart failure regardless of diabetes. We have another medication just recently coming approved called Vericiguat. It's just amazing to be part of this field today because there's so much advancement in this field. There's so much research, and there's so much you can do to improve heart function. Now, beyond that, there's even mechanical interventions. For example, I'm not talking about surgical interventions here. I'm talking about something like the mitral clip. When patients have a significant amount of leakage across certain valves, there are interventions that we can do today that improve outcomes, improve symptoms without having to open up the chest, without having to do surgery to replace a valve. We can replace or fix valves just through a procedure going up through the groin with one poke into a vein or an artery in your groin without having to do any surgery. We have a device called CardioMEMS today, which is a monitoring device that you can implant very, very easily without surgery into the pulmonary artery that sits in the lungs. So we can monitor your pressures from home. And by doing that, we can be on the phone with you and tell you, well, your pressures are rising. You need to do this. You need to improve. You need to increase your diuretics, keep you out of the hospital. But once you have done all that, once you and your cardiologist have really been on top of all the most up-to-date therapies and interventions that are available, when is it time to really say, wow, I think there are some signs that things are not going in the right direction, and I really need to be ahead of the game and on the ball and plugged into an advanced heart disease or transplant center, so that if it is time to get on the list, I need to be plugged in with them. And if it's not time just yet, I want them to know me now, because God forbid, as you see in this illustration, sometimes in the world of heart failure, you can be walking along and keeping up as much as you can for a while. And then one day, God forbid, someone can literally fall up the cliff and go downhill very quickly. And within that short period of time of somebody falling off the edge, they can lose their ability to be a transplant candidate. You could get so sick so quickly that you may be too sick to actually be a transplant candidate. And that's why it's so important to be alert and aware of certain signs. And I've listed a bunch of things here. For example, if somebody's noticed that they've had more than one or two hospitalizations in the past year, and you said, I used to always have shortness of breath. I would take diuretics. I'd get a little better and get back to my life. But I noticed I've been in the hospital now twice in the last year. That never used to happen to me. Other things to look for: how are my kidneys doing? How is my other bodily organs functioning? How's my liver doing? How's my kidney doing? Because the kidney, as we've talked about in other programs, is intricately linked with the heart. And when the heart starts getting worse, you may see that in the kidney function. And that's a very important sign you have to be monitoring all along. Are you losing appetite? Are you losing weight despite any intention to lose weight? Are you noticing that you used to be able to tolerate all your medications, and now suddenly your blood pressure is a lot lower? You're getting dizzy and lightheaded when you take your medications. You cannot tolerate them the way you used to. That's also a sign of worsening. If you notice that you are having, if you notice you're developing symptoms at a much easier or much quicker rate. For example, you used to be able to walk several blocks before you had any shortness of breath, and now you're noticing that it occurs even after one block. Or you're noticing you're having difficulty breathing when you lay down at night to sleep, and you see these symptoms are coming on at a sooner and faster pace. Another thing to be aware of is people's sodium levels, and most patients with very weak hearts will have defibrillators put in, which is a special type of pacemaker, essentially, that has the ability to shock the heart in case of a dangerous or lethal arrhythmia. And if somebody notices that they've had a shock, or they never had a shock before, or they've had multiple shocks, these are signs that the heart is not happy. The heart is getting worse. That is when you absolutely need to be plugged into an advanced heart disease center or a transplant center where people can start working you up and determining, is now the time you need to be on the list. Now, this is a really interesting statement, and it's something you have to really try to explain to patients. It's not always so easy to understand, not for the patient and especially not for the families. You have to be sick enough, but well enough. And what I mean by that is, the first question is, well, is your heart sick enough? Are you sick enough symptomatically and limited enough that you really need a heart transplant? Because as I mentioned, people can live with very weak hearts for years and years and years. And many people get referred to us because their heart is weak. Let me give you an example. One of the ways we quantify the strength of the heart or the function of the heart is by something called an ejection fraction, or EF. That means how hard is your heart squeezing. A normal ejection fraction is about 55 or 60%. Now, we have some people refer to us because their ejection fraction is 10 or 20%. And people say, well, I better get a heart transplant as soon as possible. But that's actually not the case. With the therapies we have today for heart failure, people can live for years and years with very good functional capacity, with a very weak heart because of the therapies we have today. So the first question is are you sick enough to really need a heart transplant? Are you limited enough? Is your quality of life that bad? Are you limited enough in your daily activities that you absolutely need a heart transplant right now? Have you been optimized on all available medical and device therapies already? Because we want to optimize and maximize that before we say, okay, it's time for a heart transplant. But the next question at the same time we ask is, but is your body well enough? Is the rest of your body in good enough condition to handle a heart transplant, to go through a surgery like that, get a new heart, and still come out and be able to rehab and function normally and go back to a normal life with your other bodily functions intact? And the kidney is a great example of that. That's why I said we keep an eye on your kidney function, your liver function. What about your overall physical condition? There's some people that their hearts are definitely sick enough, no question, they need a transplant, but they're so frail, they're so deconditioned that they're actually too weak and sick to go through the process. They won't be able to make it through the surgery and rehab to a point that they'll have a meaningful quality of life. And believe me when I tell you this, there are people that really get to that point where it's just too late and they're too frail. Now, when somebody is getting ready to be on a list or already on a list, we realize that there are some factors in life you can control and some things you can't control. You can't really control your age. Well, the reason why I say maybe you can is because what I'm alluding to is you can determine at what age you get plugged in to an advanced heart transplant center. So there are limitations on when you're too old for a heart transplant. In most centers around the country, that age is about 70. Other centers, at least the centers like ours that do more high volume or higher risk transplants, we usually go up to a 75 as a rough estimate, sometimes even higher than that. We've done people as old as 78, but it also depends very much on how your other organs are functioning at the time. What is your blood type? As Dr. Brookins talked about, that's something you can't control. Antibody status, which is your underlying immune status and going to affect the type of heart you can receive, what type of donor you can receive from. And remember, one of the main differences in heart transplants compared to things like kidney transplant is there's no living donors for a heart transplant. I would think that's obvious, but it's actually not that obvious to everyone. Some people don't truly understand that it means, you're taking out the heart of one person and putting it in another person. And obviously you can't, there may be other people you'd like to take their hearts from, but there's no legal way to do that just yet. So there's no living donors as opposed to the world of kidney transplant, for example, where you can have a living donor and you can set up your transplant for next month, like a C-section. But there are things you can control. And this is what I want to really emphasize today. What can I do? What can I control? What can I do to make myself a good candidate for heart transplant? And how do I keep myself on the list once I am on the list? And Dr. Brookins beautifully alluded to so many of these things, but I'm going to just emphasize some of them again. Number one, compliance. This is utterly important. This is essential because, as you know, there's so many medications that I showed you just briefly about that people should be on to optimize medical therapy. Have you done everything you can already do? Are you taking your medications properly? A lot of times we get feedback from referring cardiologists. Well, I really help this guy out, but I got to be honest with you, he hasn't come to clinic in a year and a half. He hasn't taken his medications. He hasn't done the blood tests I've asked for, he or she, and that's a big red flag. Diet, someone compliant with how much salt they're taking and how much fluid they're drinking. And then the second thing I mentioned was plugging yourself in early enough to an advanced heart disease or transplant center, which is usually what your cardiologist can help you with and hopefully is thinking about. He or she will send you to a place sooner than later. There's really no such thing as sending someone too early. The worst we can say is, well, good news. You're too well for a heart transplant right now. We'll see you next 6 months. We'll see you in a year. If anything gets worse, you let us know. That's the worst that can happen. But you could be too late. Be up to date with cancer screening, things like colonoscopies, pap smears, mammograms, and as Dr. Brookins talked about, dental. These things are really, really important. People may underestimate why they're so important. The reason is because the risk, number one, the risk of infection after a transplant when you're immunosuppressed could kill someone. Somebody has a dental infection, an abscess that they don't know about. And you put them through this transplant and immunosuppress them, that could kill them. It could infect the heart. Cancer, unfortunately, the rate of cancer and the risk of cancer is much higher once someone is heavily immunosuppressed, like we do to all transplant patients. And so we need to know ahead of time that they've had the proper cancer screening. And for men, that includes prostate, and then some of the things I alluded to. I mean, you'll be amazed. We could have patients that come into the hospital. They're extremely sick. They're on IV medications. They have devices that we put into them to keep them going, keep their hearts going, and they're not going to leave the hospital until they get a heart transplant. And during that time, we'll do a colonoscopy on them. Most people think, well, a colonoscopy, you do it every few years. It's not something that's going to make or break the deal right now. No, it's really important to be on top of those things, to keep records of those things. And then control of comorbidities, and though that by that I mean other conditions that you're treating. Diabetes is essential. It's essential to have your diabetes controlled because a number of the medications after transplant can worsen your diabetes. Steroids, Prograf. Many of you patients who are already, recipients and transplant patients already, about all this.
Right.
Weight. There are cutoffs. The BMI has to be, body mass index has to be less than 35. Your hemoglobin A1C has to be less than at least 8.5%, but the lower the better. These have to do with rehab potential, conditioning, and infection risk. Okay, things like cancer. If someone had cancer, it doesn't mean you can't be a transplant candidate, but it needs to be in remission. The risk of recurrence has to be very low. We work with with oncologists to determine that. Frailty, nutrition, age of presentation to the transplant clinic, and peripheral artery disease. These are things that you really have to make sure are under control because they could make or break a person's candidacy for transplant. And the last point I want to mention are psychosocial factors that Dr. Brookins already alluded to, but I can't overemphasize this enough. There are so many patients that I have seen that are not eligible for transplant simply because of psychosocial factors. Some of them in their control and some of them not in their control. And it breaks our hearts to see someone unable to get a transplant because they have no caregiver plan. There's nobody who can help them afterwards. There's no one who can take them to their clinic appointments, to their biopsy appointments. We do frequent procedures in the first year after transplant. A patient has to be able to come to clinic visits frequently and get these procedures done. Smoking, drugs, alcohol. These are absolutely contraindicated. When I say alcohol, I mean rare or social alcohol is acceptable, but excessive alcohol, drug use, smoking is absolutely unacceptable. And insurance companies will not pay for transplants, even if the transplant center, said, well, we feel for you. We'd love to bend the rules and let you get a transplant. Insurance companies may not pay for it. They'll say, no, sorry, you have to have 3 to 6 months of abstinence, and you have to prove that with recurrent screening. Caregiver plans, family support. It's so important because it's not just the patient who goes through this process. It's the whole family and friends and people involved. Psychiatric conditions have to be well controlled. One of the reasons these are so important is because the medication you take after transplant is a little different from just your usual blood pressure medications, for example. Somebody who goes without their blood pressure medicine or their diet or their cholesterol medication for a week or two, they're probably not going to die. But if you go without your immunosuppression for a week, you absolutely could die from that. Your heart can go into rejection, and you can die from that. And this is another one of the areas where a heart transplant is different from some of the other transplants. Yes, you could go into severe rejection of other organ transplants and you could die from that too. But, if somebody's kidney fails and they go into severe rejection, they go back on dialysis. Someone's heart fails and it doesn't work, well, they die. There's not too many options. So that's really, really important for people to stay on top of their compliance, the medications. And I brought that up under the psychiatric condition, because if people have a psychiatric condition that poses a major risk for them being compliant afterwards, that's a real big red flag. That's a big problem. I think that's basically the gist of what I wanted to say. Thank you again so much for having me, and I'm happy to take questions. Thank you.
Dr. Gift, that was absolutely remarkable. We had a response from Hope with Jonathan that says, what an awesome and informative conference. This right here is your information was just absolutely so awesome. But one thing that I got a couple of questions, and they're going to open up to the floor. But one thing that I noticed that came from Dr. Brookins and also yourself about being your body can be deconditioned. And my I guess this for me was one that absolutely loves health and exercise. And I believe that it worked really well for me before dialysis and all of that. So what is your recommendation for exercising with heart failure? I wanted to ask that. I know we're doing this in this transplant of getting prepared for, but what is your recommendation for exercising when someone has heart failure, or can they exercise? I guess that's a big one for me.
That's a great question, and a question that a lot of patients ask, because it seems sometimes counterintuitive to them. Well, how can I stress my heart? How can I put myself through exercise when my heart is weak or I have heart failure? Well, we encourage all of our patients to have routine exercise. It's actually been shown to improve their outcomes the more you can exercise. Now, granted, there are certain limitations to certain patients where we don't want them to push themselves over the edge or push themselves to a point where their heart rate gets out of control, or if someone's had a lot of defibrillator shock and stressing themselves too much could put them at risk. But in general, patient who feels they can exercise, meaning they could go on the treadmill, they can go for walks, 20, 30-minute walks a day, including going up hills, doing light weights or even moderate weights, swimming, sports. I generally tell people, unless, like I said, unless there's certain specific situations where I'm worried about them for certain reasons, I generally tell people that I don't really have a limitation on your exercise. If you feel comfortable doing something, if you can do it without feeling like you're putting yourself totally out of breath, if you feel good about it, I'm good with it. If you play basketball and you feel good playing basketball, I want you to play basketball. If you can jog, if you can jog for half a mile, I want you to jog a half a mile. So I really don't restrict people's exercise, but I do tell them in general, I don't want you to push yourself to the point that you can't go any further. I don't want you to push yourself to the max. I want you to certainly do a moderate amount of exercise where you feel comfortable doing it. And for every person, that's different. But at least something, even if it's just going for walks, several blocks a day. For some people, that's all it is. For some people, it's doing stretches or armbands if they really can't do much walking. But I encourage as much exercise as someone can do without pushing themselves to the point that they have to stop. That's sort of the guideline I usually recommend.
That's good. I got two more questions I want to ask. I was talking with, well, I guess with this, I was talking with one lady. She's actually on the transplant list for a kidney, but her sister and her mom has had heart transplants. And the thing that she was talking about was the thing like you were saying before is the kidney transplant is so different from the heart transplant. Number one, again, as you said, if the kidney transplant fails, we can go right back on dialysis and we're good. And then you said, but if the heart fails, that's it. And then on top of that, she was talking about, and we were talking about, so the fear itself of the actual transplant surgery, of how the heart is actually removed from the body, and we know we can't live without that heart, and then you take this other heart and place it back in. And so in the mentality of like someone like me that don't know anything about this is, okay, I die for a minute and then you bring me back. And she was talking about, so what if, this is the question, how do you calm the patient or the nerves of the patient, of understanding the seriousness of the transplant, that again, the heart is taken out and it's going to be put back in. How do you calm that? Because it's so different from every other transplant. So is there something that, to calm, to say, you're going to be all right? I'm just going to put it in your hands. How do you calm that mindset of the transplant recipient?
Well, for one thing, we try to give them a lot of reassurance that this is something that's been done now for many, many years, and the outcomes are excellent. The outcomes are excellent. This is that the people, the surgeons we have doing these procedures are so skilled and experienced, and people do great. People do great. And number two is, interestingly, most people, when they're actually that sick and their heart is that bad that they're waiting for a transplant, to be honest, a lot of them, I don't have to calm them about that. They just want that heart. They don't really care what you have to do to get it in, and to be honest, another point is they're not actually dead for a minute, because we never stop their blood circulation through to their whole body. So even when you take out the heart, you attach them to a machine, and that machine acts as a heart, and it helps pump blood to the whole body, to your brain, your kidneys, your liver, everything. So you're never without blood flow really to your body. So it's not like they really die for a little bit and then you have to revive them. You keep blood flow going to their body the whole time. So that's reassuring that they should know that as well. I just wanted to mention one thing that I didn't want to be misunderstood about. I said before that one of the differences, your kidney fails, you go back on dialysis. Heart fails, you may not have any option. But for people who are out there with the heart transplant waiting, that's not to say we cannot treat rejection. Many people have rejection of the heart as well. And I was bringing it up in the context of people who are not compliant. They stop taking their medicines for a week or two, and those patients are going to have a hard time getting back. But it happens to patients who are very compliant. It just happens. The risk of rejection is still there. And so if someone comes in and has rejection, it doesn't mean they're going to die at all. We have treatment for rejection. We have different levels of treatment for rejection. And even if the heart is in terrible condition, we've had to put people on bypass machines and treat them for rejection and ultimately get them off the machines, and then they go home again. So even if you come in extremely sick, there's still treatment for rejection, still ways to get them back on their feet and save them. So I don't want to be misunderstood about that rejection means it's over. That's not the case.
Okay. One response from Dr. Brookins, she said, needing a new heart and kidney does place you on a different place on the wait list. That right there is absolutely, I guess that's reassuring. I guess I don't know if it places you up. I don't know. I guess that would be my question.
The way it actually works, because we have many patients, and I'm sure Dr. Brookins has many too, who have needed a heart and a kidney. we've talked about how they're very closely related and linked. And so many patients need both. Not every transplant center does both, but many do. And so that's a very important point too. If you live in an area where you need a high volume transplant center that does dual organ transplants, you need to know that. You need to get to a place like that. Some patients have to move across the country or move to another state for a brief period of time in order to get a transplant. And later on, they can move back home potentially. Everything's stable. But if you're the status listing for heart transplants are basically a status 1 through 6 or 1 through 7. And yes, they in the last couple of years, they actually did redo the way they rank the list, the way they put people at different statuses. And a dual heart kidney does put you higher up than a regular outpatient who's just waiting for a heart alone. Now, if you're waiting for a heart and kidney, it goes by the heart. In other words, they wait to find you a heart. And when they find you a heart, they then look at that same donor and they say, okay, is the kidney also good? They don't try to find you a kidney donor and then ask if the heart is good. It follows the heart. So your chance of getting a heart kidney, let's say you needed a kidney alone and just a kidney, your wait time could be 6-7 years, in some cases. If you need a heart kidney, it's going to go by the heart. And most of the time our wait times are not that long. We're talking about, if you're an outpatient, maybe a couple of years. If you're an inpatient who's stuck in the hospital, we're probably talking about weeks to months.
Oh, okay. Well, let me ask a question on when you were talking about the patient transplant. And I wrote this down. It may sound crazy, but I just wanted to know, when you're looking at the heart transplant, and I know you was talking before that you can be a certain age to where you're too old for a heart transplant. So my question is the heart transplant itself coordinated by age? So if there's a person who may have passed away, God forbid, and that person is like maybe 25 years old, will that heart go to someone around the same age of the deceased, or will it go to someone that's maybe 68 years old?
That is a fantastic question. You really asked great questions. The list is not ranked by age of recipient or age of donor. So when an organ becomes available, the first thing they do is, it has to match up based on blood type, and it has to match up based on size. The size of the donor recipient have to be similar, and the blood type has to be the same. In the world of kidney transplant, I know that they actually are more progressive about this. Sometimes they can do things with blood types and get around that problem, but not for heart transplant right now. You have to have the same blood type. Anyhow, but the question was, what about the age of the donor and the age of the recipient? So based on the way the list matches you up, no, it will just match up who is next on the list, and here's an organ that's available with the same blood type and size. Now, the places where there is some leeway is when we have an older, we have a patient who's on the list who's in their, let's say in their 70s. Okay. That patient, I may be willing to take an older donor. If a 55-year-old donor comes along and the heart looks pretty good, and I've got a patient on the list who's 20 years old, I don't know if I'm going to take a 55-year-old heart and give it to a 20-year-old. But I may have a 72-year-old on the list, and I'll gladly take a 55-year-old heart for a 70-year-old.
Okay.
So it's not going to automatically come up on the list for the older guy, but I have the option as a transplant cardiologist, I have the option to say, I don't think this is appropriate for this guy, but I think it may be appropriate for someone else.
Okay.
So that's why there is some leeway.
Okay. All right. I appreciate you answering my questions. I believe that's it from me. We don't have any questions in the chat, so we're open up to the floor to the panel. If anyone has any questions, Jonathan.
I believe Dr. Brookins had a question.
Yeah,
before
Dr.
me.
Brookins had
I'm sorry,
a question.
I'm
Oh,
sorry.
I just had a quick comment to add on to what to the last question, that's also an important conversation to have in those early parts of the steps. So, for instance, with kidneys, we have the ability to transplant infected kidneys, right? So, let's say your hepatitis C or your HIV, you have the opportunity to tell your transplant nephrologist at that moment, I don't want to receive that sort of kidney, or I am willing to receive that sort of kidney. So, like Dr. Geff said, when that kidney does arrive, we know our patient has hepatitis C, but they are okay with receiving a hepatitis C kidney, and we move over. It's called like they call it like a high risk. It's not really high risk. There's another term that they use for it, but it's a conversation to have of whether or not I want an older kidney, or no, I don't want an older kidney. So you are able to reject organs if they are older or if they are associated with an infection. But of course, depending on how long you've been on dialysis, you may say, you know what, I'm willing to take my chances. I'm in my 60s. I will take that organ. So
Yeah,
that's an important conversation to have beforehand so that your nephrologist or transplant doctor is aware.
Yeah,
that's good
absolutely.
news.
Same thing in heart transplant, actually. Accepting a hepatitis C donor is something that we talk to everybody about ahead of time, and they have to they consent. If they want to be eligible for a Hep C donor, we consent them for that. And one of the reasons we consent them for this is because people are looking for any way they can to increase their ability to get a heart as soon as possible. They want to minimize their wait time on the list. And accepting hepatitis C donors was not acceptable a few years ago. Now it's acceptable because we have curative treatment for hepatitis C. So that's why you can accept a hepatitis C donor. And then if you get hepatitis C, which you will, it's okay because we can completely cure it with medications today. So yeah, we do the same thing with heart. And if you agree to accept that, then we put you on the list with a special note, saying that you would accept a hepatitis C donor.
Okay. We got a question from Shirley Brill. It says, "Is it UNOS? I believe maybe UNOS, who notifies the hospital or medical team about availability?"
Um, Availability, you mean about an organ offer? I assume they mean about an organ offer when it comes to. Yeah, well, you see, every hospital is basically affiliated with um, anybody on the transplant list. Of course, is on the UNOS transplant list. That's what it is. It's an organ sharing organization that is across the whole country, and they are notified by a local OPO, basically some organization that works with the local hospitals to find out when a donor has come about, and they notify UNOS that there's somebody who's willing to be a donor. So UNOS has the list of everyone who's listed and waiting. They obviously don't have a list of all potential donors, but when a donor comes about, then UNOS is notified by the hospital or the local OPO, it's called.
Okay. Thank you. I want to open it up to the floor. Do anyone have any, the panel, if you have any questions? All right, Jonathan.
First of all, I want to say, Dr. Gift, I really enjoyed your presentation and very informative. My question
Thanks.
is, as we've seen in the last couple of years, advancement in with the kidney X and the bio kidney, we even seen the pig kidney. What kind of advancements are they having and seeing with the heart transplant? Are there any advancements like that?
Um, it's a great question. It's funny because we in heart transplant we always find ourselves behind kidney transplant. We kind of follow the lead of kidney transplant. You may have read in the news this year that they did for the first time a successful heart transplant from a pig. It was a genetically engineered pig. So they had modified the genes of the pig to try to knock out certain genes that we believe are responsible for causing rejection. It seemed to go very well at first. Unfortunately, the patient did die eventually, but it was already a big step forward. Now, we have come a long way in the world of heart transplant, and the type of innovations that we've come up with so far are really management of immunosuppression and certain ways of dealing with highly sensitized patients or dealing with antibody people who have high levels of antibodies, which puts them at higher risk for rejection. So I would say that the ways that heart transplant has evolved and progressed so far have been in the way we um, knock down people's antibodies and make them candidates, even though they have high level of antibodies to begin with. The kind of therapies we give them right after transplant to protect them from acute rejection. Um, our center in particular, I think, has a specialty. One of the world famous cardiologists, Dr. Kawashigawa, he's the head of our group here, and he's probably the most experienced when it comes to dealing with highly sensitized and high antibody level patients. And so we'll get a lot of referrals from all over the country or the world because other programs will not accept these people because they're too sensitized. Their antibody levels are too high. So that's one area. Another area where we've improved upon are non-invasive tests to detect rejection or to detect high levels of rejection, a high risk of rejection. So we have blood tests now that look at your DNA. They have ways of looking at genes to detect your level of or risk of rejection. Um, and so we used to kind of rely on just the clinical presentation if someone looked like they were getting worse or biopsies. We would take up somewhere between 10 to 14 biopsies from the heart in the first year. And now we've cut that basically like in half. So we don't have to bring them in for all these procedures so many times, and do these biopsies over and over because we have non-invasive ways of measuring that. But we still kind of relying on a human heart transplant at this point. And hopefully, in the future, what I'd love to see is either we could find a genetically modified heart from an animal, or if there was any way we could grow a heart. So you take stem cells from somebody, from the patient themselves, and you grow in another heart. You know, you grow an artificial heart. I'm not an artificial heart. You grow another heart out of their stem cells and you put it in their body. That would be the ideal, because then you wouldn't have to worry about rejection. It's their own body. But we're not quite there yet.
Awesome. Thank you, Dr. Geff.
That's powerful. Any other questions? Go ahead.
I have a comment. You brought up the importance of compliance, and that's something that we stress uh, a lot on the second channel. And I hope Jonathan as well, and all other areas of transplantation, because it's very important to stay compliant. There's ways to take the pressure off yourself to stay compliant. Most of these hospitals have, like, if just getting to your appointment is your issue, you don't drive anymore, you don't have anybody to take you. Most of these have transportation systems where they'll come pick you up to get you to your appointments. Like, I know Kaiser out here has their own transportation system in a number of different steps. So they have, like, non-medical and medical. So they have where they'll send non-emergency ambulance to come get you if you're in a gurney or you're in a home or whatever. A regular car, like different types of ways. Um, as well as to you understanding instructions and things like that from your doctor. You don't comprehend certain things well. It's very easy on that. You take a notepad with you, record on your phone, take somebody with you. I would prefer to take somebody with you because now you get two sets of ears to take in with the information that's given you, and you can dissect that information together and move accordingly in the way that you need to move. So I definitely appreciate you speaking on the compliance issue, because I think that's one of the main reasons why a lot of people end up going into rejections. They stop following their medication regimen. They stop going to their appointments every 3 months, every year, or whatever their time is on appointments. Or they stop going to do the blood work or whatever the case may be. So that was a very important part in that. Yes, Dr. Brookins.
I want to add on to what you're saying. Even in the pre-evaluation phase, that's a part of what's brought to your panel, to your
Right.
committee. So if you show any issues with compliance, even before getting on the kidney transplant, that's brought before, and that could be a reason why someone is denied, right? But then if you realize the denial is from issues with compliance and you rectify those, then you can be reconsidered. So it is definitely something to attend to while you're on the wait list and even before the wait list.
That's good.
Definitely, definitely. Ms.
That's
Cook, you
good.
had anything?
Yeah, yes, I do have a question. My question goes to about caregiver, like you said. I think that's prolific when you said some of these patients aren't able to get a transplant because they don't have a support system. So what do you guys do if there is a patient that he qualifies for everything, he or she, but their support system isn't up to power? Does the hospital kind of help that person or anything like that?
Oh, I see. Dr. Brookins is giving a no. Um, I think, yeah. Do you want to go ahead, Dr. Brookins? I have something to say as well, but go ahead if you want.
Well, I'll just speak from my experience. If there is no social support, they are deemed not appropriate because the consideration, although, as Philip mentioned, some hospitals may provide transportation to get to the appointments, not all hospitals have that opportunity. So if you don't have social support, the thought is, well, you won't have someone to bring you to your appointments, you won't have someone to help remind you with medications, and you won't have someone to help you keep that kidney thriving. So they are considered not an ideal candidate from my experience.
Yeah, that's definitely the case um, with us as well. Many patients, unfortunately, have been deemed not appropriate candidates for transplant because they don't have the good caregiver support. But you were sort of asking, well, what can be done, or what do you try to do?
Yeah,
We do try to exhaust all efforts to find out, are you sure there's nobody?
right,
Can you look into your church? Can you look into relatives that live in other states? Maybe they can come live here for 6 months. Maybe you can go live with them and get a transplant there. We really, we're the patient's advocates as well. We want to try to get them there. So we do everything possible, but you're not allowed to pay for a caregiver. So that's one thing that people sometimes ask. Well, will the insurance pay for one, or what if I pay? We don't really allow that. Unfortunately, those things are not very reliable, and um, and so we'll try to with the social worker especially, we will try to work every angle to try to get them to figure out a way to make it work, and and it's not their fault a lot of the time. If someone lives alone, they didn't expect this to happen necessarily. It's they may not be married, they may not have any family around anymore, they may never have had any siblings. It's not their fault. But we definitely try to look into every angle and tell them to look into every angle. But it also has to come from them. You can't just say we'll find a way for you. I mean, they have to show the initiative, and it has to be a really reliable caregiver plan. A lot of times people come in and they don't want their friend to die, so they'll be like, okay, yeah, I'll be their caregiver, but they don't really know what that entails. And then
right.
the next thing you know, when things aren't going well, they're nowhere to be found, and they're out of the picture. That's happened plenty of times. So if you say you have a caregiver, they got to come to clinic with you. We have to meet them. The social worker has to meet them. They have to know what this entails. It's a real commitment.
Thank you for that.
We have a question in the comments. I believe this is for you, Dr. Brookins. It says, how important is the social worker for a dialysis patient to be evaluated for a kidney transplant?
The social worker is very important in dialysis and even non-dialysis. They are very, very integral part of the team. So during the monthly meetings, the social worker actually reports on who's not on the transplant list, who hasn't been evaluated, how they pretty much give updates on the transplant status. So, for instance, at the monthly dialysis meetings, they will say, well, Mr. C hasn't been evaluated yet, right? Just to kind of give a friendly reminder to the medical director, and then if it's another nephrologist that's taking care of that patient, then they will make that nephrologist aware and say, "Hey, we recommend you give Mr. C an evaluation," or if Mr. C was deemed an inadequate candidate, but there's been some updates, they update the process. So the social workers are very important with being advocates, more so, I would say, for the patients to making sure they are evaluated, especially if the nephrologist doesn't bring it back up, right? And we know that sometimes a lot of patients will say, well, if my doctor doesn't bring it up, maybe I don't qualify, right? Or if my doctor doesn't bring it up, maybe it's not the right time. But those social workers really, in all honesty, they spend more time with the patients on dialysis. And if Mr. C says, yeah, I want to be considered, then that social worker will definitely bring it up.
I want to, Trish Phillips, I just thought this was absolutely awesome. I did, because we're always talking about the caregiver for the patient. We're always talking about we got to have a caregiver for the patient. But Trish Phillips, she's a living kidney donor, and she wrote, I couldn't donate till I had a caregiver to move to that city with me for 2 weeks. And I guess like for us, we forget about, I guess, the donor. So the same way that we as kidney transplant patients have to have caregivers, the donors have to have caregivers. I guess this is the first time for me ever, I guess, taking time to realize that. And I think that's awesome. And so for those who are thinking about donating a kidney, that's something for you to think about as well. So the same thing that Dr. Gift was, Dr. Gift was saying, go to church, go to the church, go to your neighborhood, look in your family, because what you're doing is a great, great thing for someone in need. And so I just want to, I don't know Trish Fields, but I just want to applaud you for doing that, for giving part of yourself to someone else to live. Thank you. I'm just going to say thank you. I just think that is absolutely awesome. I really do. Are there any other questions? Well, Dr. Gift, we want to tell you, thank you. Thank you. Your information was absolutely remarkable. We just want to just say thank you for coming and sharing with us. We really appreciate you so much.
Thanks for having me.
Thank you so much. Thanks so much. A quick break, and this is not going to take long. I was told to give a quick break on what I do, and I am Fred Hill. I'm actually the author of Dialysis is Not Your Life. It's available on Amazon.com. Redefining your life while you are on dialysis, to let you know that your life is not over all because you're on dialysis. You can still get your energy back. You can get your life back, get your sex life back, get your groove back, get your energy back. You can understand all because you're on dialysis does not mean that your life is over. And so from the book, we actually birthed a program, Dialysis is Not Your Life program. This is a nonprofit, so we're excited about this, and it's bridging the gap between the doctor, the nephrologist, and the patient. Also bringing families in as well, bringing in counseling for the patient, because understand this things is kind of think about what's going on. I think we talked about earlier about the psyche as well, giving a place to talk. So this right here is something to come in and actually show you how to get your life back. And approved today is the Dialysis is Not Your Life workbook. So the book itself teaches and shows you, lets you know that you can get it all back. You can live your life back. Do not go and live in the cycle of dialysis. As you go to dialysis, sit back and you're losing your life. And it can mess up marriages. It can, I mean, it is something else. And so I just want to share this with you. The workbook is coming out. We will give you plans, show you exactly step by step how to get your life back from the book. So right now the book is available on Amazon.com and the workbook is coming. So I got the final proof today saying, hey, we're good, we're ready. And also please check us out at dialysisisnotyourlife.com. To see what we can help you with. It's an epicenter for all your needs, help direct you with insurance, however, those different things, and more and more and more. So please check us out, dialysisisnotyourlife.com. And for the book and the workbook is on Amazon.com. So that's me. I'm Fred Hill. Thank you so much. All right, we get ready to move back into the program. Put my glasses on so I can see. Please tell me, I hope I don't mess this up. This is Jody. Is it Keeler?
Keeler.
Okay. All right. I do apologize for just messing up your name. I apologize. Jody Keeler. Jody has been a nurse since June 2011. Jody spent the majority of her career as a travel nurse, working in various ICUs all over the country. Her interest in transplant started with her first nursing job. Jody worked in a neurocritical care unit and frequently had the opportunity to care for organ donors as a bedside nurse. In 2018, she began working as a procurement transplant coordinator with One Legacy. Due to the pandemic, Jody left that position and went back to the bedside to care for ICU patients with COVID pneumonia. In July 2021, she began her career as a transplant coordinator with the lung team at Cedars-Sinai. So everybody, please help us welcome Jody Keeler today. How are you doing? How are you doing today?
I'm good. Thank you for having me.
Well, we do want to say thank you for taking out of your time to join us on this this awesome transplant list conference. We just do appreciate you. So I'm gonna open the floor and it is all yours. You can let us know what you do and we'll go from there. So the floor is yours.
Awesome. Thank you so much. Again, thanks for having me. I appreciate it. So I am a pre-transplant coordinator at Cedars-Sinai. So I take care of lung patients, potential lung transplant patients, from time of referral to time of waitlisting. And then once they get transplanted, they move on to the post-transplant side. So most of our patients that come to us, they come by way of a local pulmonologist, community pulmonologist. So patients would be referred to us by their primary pulmonologist, and hopefully their primary pulmonologist has had some conversations with them saying, I think your disease is at the point that you need to be referred to a transplant center. And then when I get their initial referral, we'll reach out to their pulmonologist to get all of their records. Usually the things that we need to have done to bring a patient in to see our transplant physicians is they need to have a chest x-ray. They need to have had a CT of their chest. Typically they've had some pulmonary function test, which is a breathing test. Usually they'll have had a 6-minute walk test. And then we also like to see an echocardiogram or an ultrasound of their heart. So once I get all those records, I'll review them. I'll review them with our medical director to determine if the patient's an okay candidate to bring in for consult. Some of the things we're looking at that I might have a conversation with the patient before we see them would be weight. If I note that their weight is above our weight limits, I'll have a conversation with them about usually what our weight cutoff is and say, start working on some weight loss now. Another big thing that I know Dr. Geft and the other people have talked about was no substance abuse or smoking. Our cutoff is usually 6 months. So I'll make sure people know that. We'll also look at some other comorbidities. Have they had prior chest surgeries? Are their other organs healthy? Do they have liver disease? Do they have underlying kidney disease? And then what's their baseline physical activity? Usually with the 6-minute walk test, I'll know when someone's coming in if there's a potential they might be frail. And I might be able to give them some tips before they even come to see us, what to work on before they sit in consultation. We look at recent or prior cancer history. It's not a complete rule out, but usually you have to be in remission. And depending what kind of cancer, it depends how far out your definitive cancer treatment had to have been. And then also we look at social support, like everybody else mentioned, because it's a lot. It's very mentally, emotionally, physically taxing to get through transplant. And the first year, we tell everyone, is typically the hardest because you'll have a lot of follow-up. So once we determine patients appropriate to bring in for a consultation, they'll meet with our pulmonologist. That's a transplant pulmonologist in clinic, and he'll review all their records, all their images. His biggest question usually is, does the patient want a transplant? Are they invested in it? Because you have to be invested. And if they do want a transplant, he then determines, is now the time to work this patient up for transplant, or do they have time to be medically managed by their pulmonologist in the community and will just kind of follow peripherally? And maybe later is the time to do the transplant, or maybe they need some fine tuning before we actually put them through a transplant evaluation, which is all the testing and consults. Sometimes people in our perspective, need to go to pulmonary rehab, or maybe they need to be put on some other medications and be placed on maximal medical therapy. And they have more time to gain with their own lungs prior to giving them a transplant. So those are things we'll go over. If it is time to do the evaluation, we'll get them scheduled for all the testing, all the consults, and do an educational session with them to make sure that they're ready for it and that they know what to expect. So some of our requirements while being evaluated are listed for a transplant, and these can vary from transplant center to transplant center, but some of the things that we've seen, at least at Cedars and in the LA area, number one is a lot of transplant centers are requiring COVID vaccination at this time. So that's something that I'll just kind of touch base with patients and let them know. They can have more discussion with our physician as well as their community transplant doctors, but it's currently a requirement for us that they're COVID vaccinated and up to date on their COVID booster. Another thing that everybody else had talked about too is compliance is huge. And it's not one missed appointment or one canceled appointment. It's habitual. You've shown a pattern of non-compliance. It would be extremely concerning. Attend all your appointments, get all your lab draws, your scheduled testing, stay up to date on your cancer screenings. Absolutely no substance abuse while waitlisted. And like I said, or within 6 months. Patients with known history of substance abuse, will ask that they sign an abstinence agreement. And then if patients are just aware that at any time we're free to drug test if needed. So that can come at any time. And if they are active on the wait list, there's the potential that they could be made inactive for any positive drug abuse. I don't know if all programs are like this, but for sure at Cedars, we also ask our patients to be off all narcotics prior to waitlisting and for the entire time that they are waitlisted. If they need a referral to pain management or something like that, if they have chronic pain issues, we'll help them do that. And one of the reasons is just surgically, it's hard to manage patients' pain post-transplant if they're on a significant amount of narcotics pre-transplant. Wow. So that's kind of the reason behind that. We ask patients that they stay active. In lung transplant, we test frailty in 2 separate ways because all of our patients are typically come to us on oxygen. So we know that like the 6-minute walk test, when patients to determine how far they can get in 6 minutes, sometimes they're super limited because they might desat to the 80s or 70s or even lower. And they don't tolerate it. So we do something called a short physical. And what that is it's there's a sit to stand portion, there's a balance portion, and then there's a short walking distance, which is a 3 meter, and then we test gait speed. And so that in that way, we can test patients that are physically strong enough for transplant, but they maybe can't get as far as what our cutoff is for the 6-minute walk test. So some of those patients, I'll tell them, some ways to get stronger at home if they can't walk around the block because their oxygen requirements are 8 to 10 liters, is I'll tell them practice sit to stands, use your kitchen chair, put it up against a wall and just practice standing up, sitting down, using your thigh muscles and not using your hands to stand up. And, that's the biggest way that you can show that you're physically strong enough. Some of the other things that we look at, age, we do transplant. We did transplant a 79-year-old this year. But typically, greater than 75 patients need to be in like pretty pristine health. They have to have a healthy heart. They have to be active. Not a lot of other comorbidities for us to do, someone of that age. Weight, our BMI cutoff is, sometimes in lung transplant, we have patients that are actually don't weigh enough because they're burning so many calories just by breathing.
Wow.
So if their BMI is less than 17, we do talk to them about alternative options. We'll refer them to our dietitian. She can talk to them about short, frequent meals, high calorie meals. We can also talk about the possibility of placing a feeding tube so that they can get enough calories in because they're physically burning so many calories. Some of the other things that we look at would be, like we had said, social support. So we have a social worker that works specifically with our team. And one of the other things I just wanted to mention is, for people that might lack caregiver support, or maybe their caregivers have to work full time or they have kids or whatnot, our social worker is great at going through like FMLA paperwork or leave of absence, or helping you look at your company's policies to determine if you could get an extended leave and not lose your job. So that was just one other thing that I wanted to mention about that. Some of the other things that we tell patients just to stay most prepared while they're waitlisted would be to stay up to date on all their vaccinations. In lung transplant, it's very important that patients are getting flu vaccinated, pneumonia vaccinated, because the simple flu or pneumonia that maybe some of us, we'd still be able to function and we would just feel a little bit ill. Some of those random respiratory viruses that kids carry or that they can pick up, like RSV, that can really, really put somebody with underlying lung disease in the hospital or even cause them to pass away. So we just tell patients to stay up to date on all their immunizations. Another thing is post-transplant, when patients are super immunocompromised, immunizations aren't as effective once they're given after transplant. It's more effective if they get them pre-transplant. So we always recommend patients get hepatitis B vaccinated, shingles vaccinations, outside of just the flu, pneumonia, and COVID boosters. Also being up to date on their immunizations, it decreases their chances of being hospitalized prior to transplant. Like I said, they'll be immunocompromised post-transplant and at higher risk for infection. So some of the options we offer patients to stay active, specifically in lung transplant, is we can always refer our patients to pulmonary rehab, or we might require them to go to pulmonary rehab so that way they can exercise under the supervision of a respiratory therapist and a nurse, and under the direction of a physician. And that a lot of our patients love pulmonary rehab because it gets them out of their homes and it gives them confidence to move around with oxygen. Because a lot of our patients that are on oxygen, they feel very restricted because they have the fear of what happens if I run out of oxygen, what happens if, my tank stops working when I'm, 2 blocks from my house. So they teach them breathing exercises, they give them their confidence back. And, when their muscles are stronger, they're using less oxygen consumption. So they'll feel better, even though their lung condition isn't getting any better. Some patients that can't get out and about, we say stationary bikes, resistance bands. And like I had said before, just practicing sit to stands from your kitchen chair is another way to keep patients active. And also staying active, it helps with mental health as well. So most of our patients feel a lot better after going and talking to other patients. And usually in pulmonary rehab, they're able to connect with other patients who've gone through what they've gone through. Or maybe our post-transplant, and can show them, what there is to look forward to, because we send all of our patients to pulmonary rehab post-transplant as well. I had kind of talked about maintaining a healthy weight. We can always refer to a dietitian. If you need weight loss, caloric deficit, to decrease your weight. If underweight, like I had said, just high calorie meals. We can talk about the possibility of a feeding tube. And then we've also, for patients that are overweight, we have consulted with a weight loss doctor who can talk to them a little bit about their management. In lung transplant, our BMI is a little bit less than maybe some kidney centers. We typically say a BMI of 17 to 34, with 35 being an absolute contraindication. But typically we even like our patients less than 30, because, especially if they're carrying a lot of abdominal weight, it just makes it easier surgically if they're thinner. And then one of the other things I just like to tell patients while they're waitlisted is take care of your mental health. A lot of people have a lot of anxiety about waiting for the call. And in lung transplant, our patients can't breathe. So they have a lot of anxiety about dying. Especially they don't know how long they're going to wait. We tell them that the wait time is, pretty unpredictable. We have an average, but it's unpredictable. So, if you need a referral to a mental health specialist, you can reach out to your insurance to see where it's covered. You can reach out to the social worker to see what community resources there are. As far as you can go to your PCP to see if they can refer you to somebody for talk therapy. Also meditation, join a support group. There's social media groups out there for transplant recipients. There's the lungtransplantfoundation.org is like a great resource for patients that are either have been transplanted or about to be transplanted or are post-transplant, just to give people some information about what to expect and, give them some resources to read about transplant so they know what they're getting themselves into. Lastly, if they had substance abuse issues pre-transplant, we suggest they can attend AA or NA if a history of substance abuse, and also supportive care. We refer all of our patients pre-transplant to supportive care. And it's a team that kind of talks with people about what are your goals, what are you hoping for post-transplant, and they help people talk through some of those feelings of fear that they might have. Another thing, patients should continue to see their PCP regularly. They should continue care with their primary pulmonologist team. Some of the things that are important is diabetes control. If they have underlying diabetes, if their blood pressure control, stay on top of their routine cancer screenings. Make sure that they have the most appropriate oxygen prescription, because significant desats with exercise, which is, desaturating while exercising is expected if you have underlying lung condition, we still want patients to be on the appropriate amount of oxygen while they're exercising. So sometimes, we have to tell patients you can go up on you don't need to just use 2 liters. You can use 4, because we don't want you desaturating to the 70s or the 80s, because you could ruin your heart while you're waiting for a lung transplant. So just a couple things like a little significant to lung transplant. Our average wait time is about 3 months, but like I said, it's completely unpredictable. There's also no living donors in lung transplant. Patients can either be approved for a single lung or a bilateral lung or both lungs. And that's dependent on a couple of things. It can be dependent on age, and it can also be dependent on, underlying procedures. If they had like some kind of surgical procedure on one side, or if they've had a CABG or open heart surgery, that might only make them a candidate for one lung, because they can't go back into the other side.
Wow.
Also, we do dual organ. So if patients have underlying kidney disease, somebody could get a lung kidney. And like Dr. Geft had said, it would go based on where they are on the lung list. So they wouldn't, wait for a kidney donor and then be transplanted with a lung. The Hep C positive donors, we also do that with patients' consent. And like Dr. Geft had mentioned, it's treatable and it's curable, but we go over all of that with patients as well. Some other things specific to Cedars is we offer what's called a bloodless lung transplant. And what that means is people who do not accept blood products. Typically, we've seen most people with like Jehovah's Witness of that religion, they do not accept blood products. So we do offer a bloodless lung transplant, but there's some other restrictions with that. You would have to have, we would check hemoglobin and hematocrit to make sure that those were appropriate numbers going in. So that way, we know that we're doing it safely. Another thing too, specific to Cedars, is we do offer lung transplants to patients that are HIV positive. So we do lung transplant on patients who are HIV. Usually their HIV has to be very well controlled. And then some of the new things coming to us surgically is we do a minimally invasive lung transplant. So one of our surgeons that came to us a couple of years ago brought with him this surgical technique. And so the actual incision size is about the size of a credit card. And so it would be on both sides, and it's just under, just under breasts in a woman, or in under the pecs in a man. And it's shown that patients have better controlled pain post-op, and also it has shown that we have shorter hospital stays, so patients are staying in the hospital less. And then lastly, I just want to tell everybody that always, 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 you would want to keep your transplant team up to date with any insurance changes, if you're hospitalized, if you've gotten any blood transfusions, because that can affect antibodies in your blood, if you've had a change of address, if you're having any social or financial issues that could affect your ability to make it to the hospital for transplant. We always want to be up to date on this, because, we can't help you if we don't know what's going on. And then I always like to tell people is that the first year after transplant is the hardest and the most challenging. And after that, hopefully it gets easier over time and less appointments and back to a more normal lifestyle. But in that first year with lung transplant, we make so many changes in patients' medications to make sure that they have the appropriate use of immunosuppression. And so, they have a lot of follow-up that first year, and they just need to bear with us, which is also why they need to have strong caregiver support, because it's very, very emotionally, mentally taxing. We require our patients to have 2 caregivers, a primary caregiver and a backup caregiver, that we ask that they're available 24/7 for up to 6 to 10 weeks post-transplant. At least. And that's just because we know it takes a lot, it takes a lot of people to get somebody through transplant those first couple of weeks. And then lastly, we ask that our patients live locally, usually up to 1 year post-transplant, but we say usually within that first 3 months, we ask patients to live pretty close to the hospital. So that way we can see them frequently, and if they're not feeling well, we can get them care really quickly. And that's it. If you guys have any questions.
Okay. I'm gonna say this before I get into my questions. Shirley Brill, she put up a comment, said I had a double lung transplant May the 6th, 2008, a perfect match, and haven't been admitted to the hospital since. So Shirley, if you're still watching, we celebrate you for that. Is just absolutely remarkable. I want to say, Jody, your presentation is so awesome and it was so thorough. I'm gonna say this every time I would write a question, then you would answer it. I'll write a question and then you would answer it. I mean, you are absolutely awesome. And something about, I've never had a chance to interview a coordinator, and I just want to tell you personally, I appreciate you because your job is basically the glue, because you're the one that, I think of the like a spider, the center of the spider, but then you have all these legs just going out because you're touching the patient, you're touching the patient's doctor, you're touching the transplant doctor, you're touching those when they're doing therapy. I mean, you're like keeping it all together. And so on behalf of all of us who've had transplants, I just want to tell you thank you for the job that you do. That is absolutely awesome. But one question that I do have, and I want to put this, because I mean, you really, I was marking out all my questions, but I have a question dealing with COVID. How has COVID affected lung transplant? That's what I wanted to ask.
Sure. So that's actually a really great question. That's kind of why lung transplant specifically is so special to me, because I worked in the COVID ICU in New York at the height of the pandemic. So it's nice to see that we're actually transplanting these patients now. So we did have an uptick, I would say, in our inpatient transplants. So we would get a lot of referrals and transfer patients to Cedars with COVID, and a lot of those patients were very, very sick at time of transplant, but their outcomes have been phenomenal. I think we have done 23 COVID related transplants. And in the future, there'll be more to come, because we are seeing a lot of patients in consult that are, long haul. They were admitted at the beginning of COVID, and now they have, underlying pulmonary fibrosis. And so time will tell. I think time will tell, but we are transplanting patients that have lung disease because of COVID, and they're doing well post-transplant.
Okay, that's awesome. I guess another. This I guess it's not a question. Because I wanted, because you answered everything very thorough. But I want to ask a question on the people who are not yet at the place for transplant. Because one thing that you brought up, and I had the questions, because breathing affects everything. When affects walking, talking, and I'm thinking exercise, even eating. I mean, you got to breathe to eat and drink water. And my mind was just going on and on and on. So for the people who are not there yet, my question is there a website, or is there a way that they can find out more about these two things, more about breathing technique, and also more about the bloodless lung transplant? I've never heard of that before. And I mean, maybe I'm just dumb to the fact of it, but is there somewhere that they can find out more information on breathing techniques and the bloodless lung transplant? I just thought that was awesome.
So I think the best place to learn about breathing techniques is really to go to pulmonary rehab. So, if they haven't gotten to a transplant center, they can ask their primary pulmonologist for a referral to pulmonary rehab. The actual website that we use is, because we're based in California, is there's a California Pulmonary Rehab website, and it tells you the locations of all the pulmonary rehabs. So I'll tell patients, if they don't live close to Cedars and they don't want to do pulmonary rehab at Cedars, I tell them, look at this list and let me know which one is closest to your home. So it's convenient for you because it's going to be 2 or 3 days a week. And let me know, and we'll send the referral there, or ask your primary pulmonologist to send a referral there. So the breathing techniques, they teach you all of that at pulmonary rehab. So I've never heard a bad thing from a patient that's went to pulmonary rehab. They've all loved it. Some of them are a little hesitant in the beginning. And then once they get there, they're like, it was a great suggestion. Glad that you guys sent us.
Okay. All right. Appreciate you answering my questions. Is there anyone else on the panel that you may have a question for Jody?
Yes, Jody, that was a wonderful, informative presentation. Because, like he said, every time I asked, I had a question, you was going right to it, and I was like, "Daggone!" So that was really really thorough. But just like Fred said, with infections, so after the transplant, what do they have to watch out for with the infections? Just like what Fred said, because you're breathing in and out all the time and stuff. So is it like, do they have to watch going into public places or anything like that?
Yeah, so our transplant center doesn't require it, but there are some lung transplant centers that they actually tell lung recipients to always wear a mask after transplant. We don't tell patients that, but we do tell people, it's almost like our recipients have been, social distancing pre-COVID. And so we do tell them, if they have immediately post-transplant, they can see their grandkids or little kids like that, but they probably need to keep their distance. And during cold and flu season, frequent hand washing, up to date on all their vaccinations. They should avoid large crowds, much like COVID. Or they, if they're going to go in a large crowd, they should, wear a mask or something like that. So those are some of the things we do tell patients to do post-transplant.
Another question I had was, when they do a transplant, do they give a whole lung, or does the lung regenerate, or how's that work?
So they do a whole lung. There is the possibility that they could shave it down if the size was a little bit mismatched, but very, very infrequently that happens. So patients will either get one lung or two lungs. And, there's a reason that the surgical team determines whether or not one lung or two lungs suffices. And part of it's age too, because our patients that are over 70, sometimes they're at higher risk for a longer surgery if they do two lungs versus if they just do one lung. The surgical time of doing a single lung is, 3 to 5 hours versus double that.
Got you. Now, do they take the same medications? Like, I take the CellCept, Prograf, things like that. Do they take the same ones?
Yeah, yep. They will be on immunosuppression, and kind of like Dr. Geff mentioned, with lung transplant, if you're taking your meds erratically, so we tell our patients to take them at the same time of the day, every day, never miss a dose. Always make sure that you have adequate supply if you're going on vacation. Give your transplant team a heads up if you're at your last couple of pills. If we tell our patients, if you're feeling nauseous and you weren't able to keep your pills down, call us, because we want to be able to tell you what you need to do with your next doses. So yeah, they're on much of the same medications, but I think the levels that we're looking for is probably a little bit different with lung transplant than with some of the other transplants.
Okay. Thank you so much. I appreciate that. Like I said, you were so thorough. Those are the only questions I had because you killed the game.
She did. Philip Jones. Philip has a question.
Yeah, two questions. One is directly to you, and the other one is really kind of for everyone that you guys and the rest of you can answer after we get done with Dr. Chen on everything. But does every medical center have a pulmonary rehab?
I'm not sure on the answer to that. Cedars does have a pulmonary rehab. And the one barrier with pulmonary rehab is I don't think that there's enough of them. Because frequently our patients will end up being on a long wait list. So they might not be able to be seen for like a month or 2 months or something like that. But I'm not sure about all the other centers if they have their own pulmonary rehab. Ours does. And frequently they'll try to squeeze our transplant patients in. Like if I have a patient that's frail and I suspect we might be able to list them or move forward with listing them, I can usually work directly with them and be like, can you get my patient in for like a cancellation or something like that? Because being listed is really dependent on them getting stronger and seeing you. And so usually they'll be able to work a little bit of magic.
Awesome, awesome. And my follow up question to that is that if they don't have pulmonary rehab, is there a substitute for it?
So for like heart transplant, there's cardiac rehabs. It doesn't necessarily have to be pulmonary rehab. They could even work with, some of our patients are actually too sick to even go to a center for pulmonary rehab.
Wow.
So we'll order home physical therapy. So there's all kinds of options. You could do home PT, you could go physical therapy, you could go pulmonary rehab. Or like I said, get resistance bands and ask somebody what kind of exercises you could be doing at home.
My last question, and this is like I said for everyone. I know Dr. Brookins stepped away, but Dr. Geff and Dr. Chen can answer at the end. Is it a must for someone to get their COVID vaccination before they get placed on the transplant list?
Yes. Currently, it's a yes. I would imagine. I'm not sure if it's unanimous across all transplant programs in the country. I think it probably is. At our program, it currently is the policy. Is it the same, Jody, in lung and in liver, Ellen?
It
For
is the
liver,
same.
yes, we do require it for liver. For the acutely decompensating patient, for the COVID vaccination to occur after the transplant surgery, but otherwise,
All right. Jonathan?
I think Jody needs to answer the question too.
Oh, so in lung at Cedars-Sinai, yes. And I do know that a lot of lung centers, just from like patients that have called me request or inquiring about our COVID vaccination policy, a lot of lung centers are currently requiring it, but it's completely up to every center. But Cedars-Sinai, it's a requirement.
Ah, that's good. That's good.
It looks like Dr. Brookins wrote that they do require it, and they're even doing testing while on the wait list.
Wow, that's good.
Jonathan, I believe you had a question.
Yes, I do. Great presentation, Jody. Thanks for doing that tonight. And my question is on the level of immunosuppression. As you know, the immunosuppressants such as like tacrolimus, CellCept, as we know, as kidney patients, that they're actually been known to be actually nephrotoxic as well. So I was just wondering how high of a level of Prograf CellCept, if that's what you're using for lung transplant, how high of a level do you guys normally start with a fresh patient?
So I can't speak to specific levels because I have never worked in post-transplant with our team, but I can tell you that over time, so after a patient's a year out, 2 years out, they do go down on their their acceptable level. So in the beginning, post-transplant patients are at that higher level of acceptable. And then over time, as their transplant, and if they haven't had rejection and they haven't had any issues, they'll start backing off on it and letting the acceptable normal be a little bit lower than in that first year.
Yeah,
Okay, thank you.
In heart transplant, we aim for, generally speaking, we aim for a level of 10 to 15 for the first month. And then we drop it down to like 8 to 12 or so for the second and third months. And then long term, basically, we maintain them around 5 to 10. That's sort of the maintenance level, 5 to 10. It depends. If they end up with infectious issues, we drop it even lower. If they end up with cancer, we drop it even lower. If they end up, so, but that's general policy.
All right. Just want to say thank you again, Jody. We appreciate you. Got to do this right here for you. Thank you for coming, sharing your presentation again. Just absolutely awesome, awesome, awesome. I do want to say recognize Lakeisha Bray. She's a donor mom for Talia Joy. So again, for those who are on here, I just want to take this time to celebrate again, because we found out, knowing that it's not easy. Well, appreciate the love and the courage that you took to donate the organ that was needed. So we celebrate you, Lakeisha, today. So we're going to take a moment. We're going to take a break, and we're going to talk about Creamy Crack. Creamy Crack. What is it? Creamy Crack Body Cream. Creamy Crack Body Cream. All right. We'll be back.
Hi, everyone. I'm Camille Cook, the family nurse practitioner, the creator, the developer, the chef, and the cook of crack. Well, Creamy Crack, the addictive, all-natural body cream. I have a background in dermatology and cosmetic surgery, and I created a 98% organic and a 2% all-natural body cream in 2011 for both my son and husband. My son, who suffered from the irritating symptoms of eczema, and my husband, who was a 2-time kidney transplant survivor and who was on kidney dialysis for over 10 years. They both suffered from the dry, itchy, scaly, and flaky skin. And as a mom and a wife, and with a background in dermatology as a nurse practitioner, I couldn't stand back and see them suffer any longer. So I got into the kitchen and started cooking crack. Well, Creamy Crack again, the all-natural body cream. It moisturizes, it replenishes, it restores, it heals and protects your largest organ. You got it, your skin. I have been able to make such a difference in the lives of those people who suffer from the irritating symptoms of being on kidney dialysis or who are awaiting a kidney transplant, and also for those who suffer from eczema. Those people or individuals have suffered way too long and tried too many things to help their skin come back to life. I am so honored and grateful for you to try this all-natural body cream. Again, that's going to help you look and feel better with your skin. Creamy Crack can be found on all social media platforms at Creamy Crack Body Cream, or can be purchased at creamycrackbodycream.com. I look forward to serving you, sharing with you, and making an impact in your life. I hope you'll go out and try Creamy Crack, the addictive, all-natural body cream. Thank you.
All right, we're back. We're back. Make sure you check that out, Creamy Crack Body Cream. I absolutely love that commercial. Every time I got to the kitchen, started cooking. This is what I came out with. I love it. So, make sure y'all check that out. Right now, we're going to move on next. We have Dr. Alan Chin. He's here tonight. Dr. Alan Chin is a general surgeon at Cedars-Sinai Medical Center, received this degree from UC Davis. which he then pursued his dreams in the medical field by going to medical school at Georgetown University. Dr. Chin then did his residency at UCSF Fresno and completed his fellowship at Cedars-Sinai Medical Center, and has been in practice between 6 to 10 years. Listen, everybody, let's welcome Dr. Alan Chin tonight. Glad that you're here today. All right. I think he disappeared for a second. I don't know what happened.
No, he's right here. Give me one
Got
second.
him? Okay. All right.
Oh, hold on. He popped off in a second. I think he's. Oh, here you go.
Am I
All
back?
right.
Can you hear me?
Yes, you're back. You're back. You're back.
Bob,
Thank you. Thank you for taking the time tonight to be on the Transplant List Conference. We really appreciate you taking the time. Thank you so much. So, Dr. Chin, we're gonna give the floor to you. It's all you. Your presentation. Thank you so much for coming.
thank you guys so much for having me. I'm more than happy to come here and chat with our interested in liver transplant, and ways that you can maintain your status. I think you guys are doing a great thing here. When it comes to liver disease, it comes usually in about two flavors. Okay, you get very sick and you're called decompensating. You're decompensated, so you need to get a liver transplant as soon as possible. These patients are usually in the hospital to get their work quickly, and they need to get a liver. I imagine for most of the patients, this talk would be for the other kind of patients who need a liver, and that's a chronic liver disease in the outpatient setting. And what you would do is, it's a lot of been addressed, which is you want to speak with your primary care doctor, you want your hepatologist, transplant center, and at that point, they would go ahead and get the workup. Here at Cedars-Sinai for liver transplant, it's a large team, just like transplant. We'll have a lot of people working with you, including your coordinators, your hepatologists. You need to have all of your screening, your general health screening, up to date. So if you have a colonoscopy, if you're a woman, you need to have your mammogram if you're greater than 40. And you also need to have your gynecological pap smear, because after transplant, you are particularly high risk for cancer from immunosuppressor, that your risk for cancer going into transplant is as low as possible. Likewise, you need to see a cardiologist. We want to make sure your heart is okay to tolerate a transplant operation. And then what happens is there's a long screening module or timing where, for example, every 6 months you need to get it, because a lot of patients who have chronic liver disease will develop liver cancer. And we constantly want to screen you. Even if you already have liver cancer, we all want to constantly be spread, and you're still within a good candidate for transplant. States the most common reason for a liver transplant about 10 to 15 years ago was alcohol has always been sort of number two, but we're starting to see a huge rise in fatty liver, non-alcoholic steatohepatitis, also known as NASH. I think around 2000 became the number one cause to be listed for liver transplant, although I don't think it's a cause for transplant as of yet. But we're seeing a large rise in this, particularly because in the United States. So people who have diabetes, who are developing liver disease. So what can you do to be a good list? I think the number one most important message I can deliver is don't drink alcohol. Not even if your cause for liver disease is or for needing a transplant, cancer or autoimmune or something, or NASH, something that's not related to alcohol, to abstain from alcohol. A lot of times I meet patients who, they've known they've had liver disease, but that message was never delivered. And it causes a lot of problems ready for candidacy for transplant if we find out you've been drinking alcohol prior to transplant. So not even a little bit, completely abstain. If you do have a history of alcoholism, you can still be, but it's important that you stop drinking right away and you take part in things or any other support groups to help you stay free of alcohol. And this is the most important thing to keep you on the list. The second, maintain all of your appointments and your screenings as scheduled, such as the colonoscopy. All these things are important that they stay up to date. If you happen to be one of those patients who are outpatient, you're not in the hospital, you're not acutely decompensating, being up to date on all of these things help you avoid any hiccups, because what can potentially happen is sometimes we have patients who say, oh, we got a great transplant, this patient, and we find out the MRI is 18 months old, and in for an MRI, who knows if they're still a good candidate. So absolutely important to maintain your appointments, communication with your transplant coordinators. Lastly, it's also important that you maintain, I know that's would be very challenging with patients with chronic liver disease, who do well and maintain, or people who exercise routinely. Chronic liver disease, you get fatigued very quickly. So it doesn't have to be a big gym routine, marathon. Something like an 8-minute walk every single day, or climbing some stairs, is enough to kind of maintain. And likewise, if you do have fatty liver disease, trying to control your diabetes or weight is also absolutely important too. Here at Cedars-Sinai, we also have a BMI for which we can safely do a transplant. Is there any questions so far? Is there anything I can help answer? So I don't have any slides.
Okay. All right. Well, we want to say thank you, Dr. Chen, for your presentation. I do have a couple of questions. This question here is because I do because of you can donate, your liver transplant. It can be pieced out, is what I was told. You can piece it out and it would grow, like you take part of the liver, not the whole liver. So my question is the percentage of live donors, is it higher than the deceased because you only take part of the liver? Oh, he went out again.
Yeah, give him a second. He'll be back.
Okay.
Here he is.
Yeah, sorry about that. So I
that's
heard the
fine.
question. The question was transplantation from a living donor.
Yes.
Okay. Yes. So when there are living in the United States, it's not very frequent. I would say, by and large, the vast majority of liver transplant liver coming from a deceased donor. Often, there are some centers in the United States that do living liver donors. A very large percentage of transplant centers that perform this, and 2% of the liver from the donor. And you're absolutely right. The liver can. So there's a very large process to make sure that the person is healthy enough that they can tolerate having that portion of their liver. Okay, and you're right. It completely grows back, and we certainly have seen it before. Commercial liver transplants, and by the time they're an adult, the liver can grow. It's amazing. It's one of the 2 tissues in the body, liver and bone, are capable.
Wow. Well, I got another question. Now, this may sound it's coming from me because I don't know anything about it. So this is gonna sound strange, but I want to ask this question. So if you can take the liver as partial, and this is my question. So the liver, when you transplant the liver in partial, and like you said, it matures, it grows. So my question is, so if you put the partial liver in, does it work at a smaller percentage? And then as it matures or as it grows, then it start working more as it grows? Or is it as soon as you put it in, it's just like boom, it's flowing?
So as soon as you put it in, I think the better question is it working enough for the recipient?
Okay.
Very important. Things like a size match for liver is critically important. For size syndrome, for example, is a condition where someone can't be transplanted a liver that got a whole liver and it's a good functioning working liver, but it may not have mass to support the person giving. So having a matched sized organ is very so when we do these partial liver transplants, we always need to make sure that liver that's too small that will not be able to sustain for the recipient.
He went out, Philip, for a second there.
Okay, I think I'm back.
Okay. Well, what I got from that is that it's like you were saying, it's more about making sure that the liver is the proper size for the transplant patient, and so if it's not the right size, then it's not going to work like it's supposed to be for the patient. So is that right? What you were saying?
Exactly, 100%. And we always try and get. That's actually one of the big barriers sometimes for transplant or very large patients is to find an organ that will fit appropriately.
Okay. Now, I guess my other question, I just want to see, because I know talking with Dr. Gift, he was talking about with the heart transplant, if they're really sick and then they're in the hospital, then they'll have a heart, and if it's available to give. So is that the same way when you said there's two levels of for the liver transplant, sick, very sick, and then like I gotta have a liver right now. So if that person is in the hospital and that liver is failing, does that like skip the list? And if it's available, it comes to that patient?
There is a grading scale for priority, and it's an MELD, model for end stage liver disease, and it's based off of blood tests to get someone's liver disease is. It's very sobering, and oftentimes it calculates what survival are in 6 months without a liver. And the higher you go up on the list.
Okay.
And so and that's so people who are, for example, as an outpatient, they typically have lower MELDs, and we're frequently monitoring them very closely to see whether or not they could be advanced further up. People who are in the hospital who are very ill, they generally have very high MELDs. Very high MELD score. Generally, you cannot be out and about in public. You're just too ill to not be in the hospital. And so that's how we get it. But we also to get livers for patients who are in the outpatient setting, and there are ways onto their MELD score based off of certain criteria. It's very just because you have a low MELD score doesn't mean that you can't get a liver.
Okay. Well, for me, that's all the questions that I have. All right, Tafara.
Yeah, that's the question I wanted to know. You kind of answered it, but I wanted to get a clarification on, you said the low mount score. How, like, unlike, kidney transplants and dialysis, you can wait for years, on the list. How long have you seen somebody go without, with really, really low score and still live? And what do they do to keep that person alive and functioning properly while they're waiting for that transplant? Because there isn't anything like dialysis.
And that is a point of intense research. Um, most organs in the body, you have some way of call it bridging technique to keep them alive. For example, for dialysis, for kidney failure, you have dialysis. You can sustain for several years. For heart disease, it's not ideal, but there's a lot of technology. You have LVADs, you have all sorts of artificial heart pumping techniques. There's nothing that's good. There's nothing that works very well. And so you're absolutely right. And I've never seen anyone on this wait list for more than 2 years of a liver,
Okay.
and you get listed for transplant. You need to get one. And for example, MELD score of 30 points, which is considered very high in states and where you are, in which transplant.
All right, Mr. Hill, we can go ahead and go to this last commercial and then wrap it up.
Okay. All right. Well, the last commercial that we have, let me make sure I got this right. Looking in here. I don't have another commercial. Creamy Crack was the last one. It was the question.
Yeah, remember
Oh, my bad. The why not? My bad. I apologize. I totally apologize. I'm so sorry for that, man. Please forgive me. We got a closing break from the Why Not Foundation. I do apologize. I was looking at that versus the my what you said.
It's all good. It's all right. Nobody's perfect, brother.
All right. Thank you. I will be right back.
Hey, what is going on, world? Edward, Mr. Why Not Drake is here. Hope you all are having a fabulous day. I just got on here real quick just to ask you all to please consider supporting the Why Not Foundation annual Why Not Impact Lives holiday drive, where we go across the country delivering gift bags to pediatric transplant patients and families at various treatment facilities and hospitals. And this year, we'll be adding a little extra seasoning by treating families to dinner. We'll be giving them gift cards so they can go out and buy turkey, some ham, chicken, whatever they're into, and just bring their families together. Because, you know, we're all about connecting and bringing families together and brightening the lives of people. So I ask you all to please consider supporting us by visiting www.whynot.org, spelled YNOTT.org, to make a donation to our holiday drive session. And also, I ask you all to follow us on all social media platforms at Why Not Connect, spelled YNOTTCONNECT. And just like my hat say, just believe, and I'm trusting and believing that you all will support our efforts this year and help us impact and brighten the lives of many people. Why not? Have a great day, and God bless. Take care.
Oh, that was good. That was good. Why Not Foundation? Why not you? So that's when you're looking at now. We just want to take time and say thank you to everyone for being on with us, whether you're on Facebook, whether you're on YouTube or LinkedIn, whatever platform that you're on. We want to say thank you for tuning in with us. We also want to give a shout out to all the collaborators, A Second Chance, kidneycarecoaches.com, Hope with Jonathan, MMDF, Multicultural Miracle Donor Foundation, and Dialysis is Not Your Life. So we want to welcome tell everyone thank you for coming in tonight. So I'm going to turn it back over to Philip Jones.
Hey, I just want to say one thing, though. I want to say
I'm sorry.
Our host was wonderful. Okay, he pulled it all together, and Fred, you did a wonderful job. So we got to give you your flowers too, brother. All right, I just wanted to say that you did a wonderful job, like you always do, and we appreciate you.
Thank you, man. Thank you so much. I totally enjoyed it. First time ever hosting something like this. So I appreciate the opportunity. Looking forward to the next, man. Thank y'all so much. Thank you so much. All right, Philip.
All right. Like Frost said, Mr. Hill, man, we appreciate you. You jumped right in there when I asked you to be a part of this conference, man, and we couldn't have the better host to do it. All three of us have done this ourselves, and I think you kind of killed it and blew it out the water. So we appreciate you 100%, brother. Thank you.
Thank you, man.
Everybody that watched, we appreciate you. Everybody that'll be watching down the line, the replay. Thank you for tuning in and supporting Second Chance Hope with Jonathan, Kidney Care Coaches, Multicultural Miracle Donors Foundation. Dialysis is not your life. We appreciate your support and your love. We got a lot of things coming in this next year that I won't speak on just yet till things get situated. So look for that from all of us. We all got our sleeves that will be coming out. So the one thing I do want to touch on though, and Mr. Cook didn't touch on this, but he has a book coming out called The 10 Dialysis Commandments that I'm looking forward to reading for sure.
Yes, sir.
We got two authors on this mug, man. I'm excited about this. Um, you know, um, I also got my book right here. I read
Amen.
that consistently. But yeah, man, definitely looking forward to $10 commandments, man. That's my next read for sure that I'm looking forward to reading. So definitely appreciate all three of you gentlemen. Trish Phillips will also help facilitate this as well. Like I said, we got some things coming down the pipelines within these next couple months and next year that I'm very excited for. So stay tuned, stay engaged, stay involved. We appreciate you all. We love you all. Mr. Cook, Mr. Trailer, you got anything?
Yeah, I just want to say, Phil, man, you knocked it out the park putting this together like you always do, man. So hats off to Philip Jones and Second Chance. You know what I'm saying? Phil puts it together. He's the mastermind of all these things. I'm just a supporting hand, but Phil is the mastermind. So Phil, once again, man, and it does want to give you your flowers for doing a great job putting this wonderful conference together.
Yeah. Yeah, I
Many
totally.
doctors on we had just Dr. Yo part you could think of, and it was wonderful, man. And we appreciate you for this information because I'll tell you right now, as we work with patients, as Fred works with patients, I work with patients, Jonathan and yourself, a lot of people don't understand how to stay on these lists. And this is a gem that people need to check out because this is information that can help people go a long way. So I just want to thank you so much for being the catalyst of putting this together, brother, for sure.
Right. Right.
Absolutely. Absolutely. Great job to everybody tonight. Everyone from our hosts to the panelists, all the doctors. Another amazing conference. And again, my hats off goes to Phil for all the hard work that he puts into this. A lot of passion, and just sitting back and watching him continue to grow and evolve with his podcast. It's amazing. And Philip, man, just keep doing. And Tafaro and Fred, you guys just continue to grow and evolve and do great things. And I'm proud to be a part of it. So thanks again for inviting me.
Hey, the Phillies mutual to all you guys.
Yes, sir. Yes, sir.
Definitely,
Yes, sir.
definitely. I want to state this since we giving out flowers. I want to give my flowers to Jonathan because what most of the people don't know is that when I started doing podcasts, the first person I reached out to was Jonathan, and without a doubt, he helped me every step of the way. With every question that I ever gave him, he had an answer for it, or he had somebody that had an answer for him. So I want to thank Jonathan and let him know that I appreciate him. It's the reason why, I've always said that the people who have been there for me are coming along this ride with me. And Jonathan's definitely been one of those people who have been there for me from the very beginning since I started saying I wanted to do a podcast and started it. I went to Jonathan and said, "Hey man, how you doing? What platform you using? What doing this, doing that?" And he answered it for me, man. And I definitely appreciate you because you are a big reason why Second Chance is moving the way it is. So thank you.
I really appreciate that. I'm humbled by that, actually, Philip. And anytime you need anything, just reach out, man. I'm here for you.
I
Awesome.
appreciate you, and I appreciate you, brothers, as well.
Yes, sir.
Mr. Cook on with me every week, doing the thing on the podcast, man. Fred Hill, every time I call him, the man picks up, of course, unless he on a cruise with his wife or something like that, and he
Eating burgers, eating
and,
burgers,
and he
eating
can't
burgers.
get to the phone fast. You're right, eating burgers and seafood and doing the thing without me of all things, though. But I mean, you gotta have that quality time
He
with your
said he
wife,
couldn't
brother.
stop
I
eating the
understand.
burgers.
I
He said he was
understand.
right there every time they opened up. Like, give me what
Right.
you knew just what you wanted on it too, didn't you?
I did, man. I did. I'm not gonna lie. I ate horrible. But when I got back, man, I got it back right. Got back in the gym, started
It's cool. I think
eating.
it's great to just get away and eat horrible for once. Like, I don't care. I'm just going to just
Yes,
enjoy myself. I think
I
that's
did.
wonderful, man.
Yeah.
I did, man. I did. We gotta do it every once in a while. You can't live like that every day. That's the thing. You can't do it
Right.
every day. So do
As
that,
long as
man,
it's
and
in
get on.
moderation, you good, bro.
I
Right,
would have just
right.
liked to been on that cruise and watched and seen how many people he inspired. Because when I
Wow,
listen
man.
to Fred, man, he inspires me every time. So
Okay,
I
for
can only
real.
imagine in
Yeah.
person him telling his story on that cruise or talking to someone trying to inspire them. So
Wow, man.
I bet that was incredible.
Wow, I did do it. I mean, when you go and you got to talk, and people ask, they always ask what you do, and then it turns into something. Then you
Yeah.
meet people, and my daughter this, my daddy this, my cousins, and my husband. He'll be down in a minute. Could you talk to him? And so, it was one of those things. I thought my wife was gonna say, "Just be quiet, don't say nothing to nobody." I thought she was gonna do, but she did it. She did it. So it was pretty cool, man. I just enjoyed everything, getting to dance and all of that, and then seeing people. For me, for those who are watching, seeing people on there who one brother didn't have no legs, but he was getting it. You had different people, man. Whatever their circumstance was, And to me, I think life is too great for us not to live it. And so, regardless of whatever the circumstance, situation, whatever your excuse may be, get on. I mean, live. I don't care. It ain't got to be on the cruise, whatever you want to do. But I'm just saying, live. Don't give yourself an excuse to remain where you are. There's too much life out here, and life is waiting on you. And if you don't go get it, if you don't go live it, you're gonna remain where you are. And so, for me, I encourage everyone watching, go get life, even while you're waiting on the transplant. Still live. Still live.
Yeah, I use this analogy every chance I get, really, but it seems like it just fits every time Fred opens his mouth. Um, it's your reset button.
Yes. Yes, it
When
is.
you get away like that, and you take that time to just get away from your normal everyday life, it's that chance to just kind of reset, get your bearings together, to take that next step into whatever it is you're doing, whatever venture you're doing, whatever business you're in, whatever nonprofit you do, or whatever the case may be. It's just that chance to just kind of gather yourself, get it together, take that next step into whatever it is that you're doing. So that's probably one of the best shirts that I've seen in a long time is reset, because it fits pretty much everything. So again, gentlemen, I appreciate you all for being on today. I know it's a little later on pretty much everybody's side. It's only almost 6 o'clock on this side, so I can go out and party if I want to. But
Right. Right.
so again, gentlemen, thank you very much. Definitely looking forward to planning the next conference that we have coming up. And you all have a wonderful and blessed night.
All right. You gotta be blessed, man. All right. Bye bye.
Peace.